Great, and agenda. So we'll go ahead and get started. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. We're going to get started with roll call. So Tara, can you help us out with that, please?
Sure. I'll start in alphabetical order. Oscar Arana.
Present.
Ebony Clark. All right, we know that Jessica Gomez can't be here today. Kirsten Isaacson.
Here.
Brenda Johnson.
Here.
Melina Moran. Oh, I see. I just admitted her into the room, so she's on her way. Bill Kramer.
Here.
Sandy Sampson. I saw Sandy earlier. Okay, maybe she just can't get off mute. Okay, John Santa.
I'm here.
Okay, great. And then I'll just give another call for Melina Moran and Sandy Sampson in case their mute buttons were not working properly.
Melina Moran is present.
Thank you, Melina. And then I can connect offline with Sandy to make sure she can hear us. We have quorum. Thank you, everyone.
Thank you, Tara. So as I mentioned already, today is our last OHPB meeting of 2022. Just a reminder that starting in January, we're going to test a new holiday meeting schedule to support members, community, and staff participating in OHPB meetings. Next year, OHPB will continue to meet on the first Tuesday of the month, except for the months of January, July, and September. During those months, OHPB will meet on the second Tuesday of the month to ensure our meetings do not occur right after a holiday weekend. So second Tuesday meetings dates next year are January 10th, July 11th, and September 12th. Also, we are entering a leadership transition period for the agency and the state. Our new governor will bring new ideas, priorities, and leaders next year. OHA is experiencing or will soon experience several key leadership transitions. For some, change can be difficult, but change can also be transformative. As we move forward during this transition period, the Health Policy Board's role will be critical in providing consistency, historical knowledge, and as we continue to support the agency to reach its 2030 goal of eliminating health disparities. Today is Director Allen's last OHPB meeting. We will get to hear from him soon when he provides his agency update. After his update, I welcome board members to share their thoughts, stories, and gratitudes for Director Allen's leadership to OHA and OHPB. So here's what we have on today's meeting agenda. So for today, we are going to hear Director Allen's last agency update. OHA and the Oregon Department of Human Services staff will provide progress updates on public health emergency unwinding. We'll get a preview on the upcoming 2023 legislative session. We'll hear from public comment. We will also get an update and proposed membership request from the Health Equity Committee. Please note the membership request requires an OHPB vote of approval today. Also, the Health Equity Committee is bringing a big question for us to consider. And that question is, how can we sustain the advances Oregon has made in advancing health equity and continue our work to eliminate health inequities by 2030, given the upcoming transitions? We'll hear a CCO 2025 contract procurement update. And finally, we will have a bridge program presentation. So our first order of business this morning is to vote on the draft November OHPB meeting minutes. The draft minutes are listed as attachment number 1 on the members meeting packet and are posted on the board's website for public viewing. Is there a motion to approve the draft November meeting minutes?
So moved.
Second.
All right, thank you. All those in favor say aye.
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 Anybody opposed? Anyone abstain? All right, those are approved. Okay, as I mentioned, this is Director Allen's last agency update. His last day at OHA will be on January 9th. So we unfortunately will not get to hear from him during our January board meeting. I just want to say, Director Allen, it's been wonderful working with you and your team over the last 5 years. You've led the agency during the most critical time of its existence. You and your dedicated staff kept Oregonians safe during this pandemic. And you've moved the agency to prioritize and help integrate and align health equity as a practice. So thank you for all your work. And again, after your update, I'll ask board members to share any thoughts or comments that they also have. So thank you.
Well, thanks, Chair Arana, for such kind words. Let me start with just a little bit of a quick update on where we are. I was going to say pandemic-wise, maybe I should just say disease-wise, as there are a few of them out there. You've, I'm sure, seen media reports and some of our internal reports on what people are calling the triple-demic of RSV, influenza, and COVID. It just in sort of general terms, I don't actually care for the phrase triple-demic. I think this is now beginning to look like what our respiratory season potentially is going to look like going forward. This is, I think, a particularly bad one for a variety of reasons that do have to do with the pandemic and some of our non-pharmaceutical interventions and those kinds of things over the past couple of years. But as we think about circumstances right now, they're sort of all piling up to create a really dire circumstance in our hospitals. Our hospitals are, for all intents and purposes, full. That's especially true of pediatric capacity, and especially within that capacity, pediatric ICU beds, which not just in Oregon, but all up and down the West Coast and into Idaho, the places that we would ordinarily think to send people for additional capacity are all, from a practical standpoint, full. There are some encouraging signs that we may have hit the peak on RSV, but as Dr. Seidlinger points out, when you hit a peak, that means you've come up to a peak and you have that same space to go back down again on the other side. And so the fact that we maybe have peaked, it does not mean we're out of the woods for a while yet. COVID is turning. Actually, in contrary to I think our second to most recent OHSU projection, hospitalizations are up fairly dramatically in the last 2 weeks. The good news there is ICU utilization for people with COVID is not having the same increase, which means, I think we're finally at that point where disease severity is delinking a little bit from infection, so that a COVID infection, given the pretty significant amount of prior exposure and or vaccination, now is less likely to result in serious illness, and that puts less pressure on the system. But a big increase in people hospitalized with COVID, even if they're not in the ICU, still puts stress on our hospital systems. And then the third area is influenza, where unfortunately we're just getting started. If you look at the national flu heat map, the Southeast, they had to invent some new colors at CDC for how much flu there was in the Southeast. They seem to have passed that peak, but they were a good 6 or 8 weeks of intense infection getting there. And we're still moving up that slide. We're a little actually behind California and Washington in terms of that rate of infection, and that hospitalization pressure is there as well. The other dynamic going on is obviously staffing shortages that cause just the whole number of beds to be less than it otherwise would be. We still struggle with getting the general public and sometimes policymakers to understand that a shortage of beds is not about mattresses. It's about the staff to be able to successfully staff those beds, and especially ICU beds. But that same staffing impact is occurring in long-term care. That is again worsening. We have, I think, as many patients boarding in emergency departments, which are stacked up behind people who are in hospital beds who then can't get out into more appropriate care settings. That circumstance is as bad as it's ever been during the pandemic. In short, I think we successfully, throughout the entire pandemic, avoided getting to the place that we are today in terms of hospital capacity, where things are truly at or on the verge of becoming overtopped, and we probably don't see a significant turnaround in that for some weeks as we think about these different elements of respiratory virus. The last thing in the parade of infectious disease is Mpox, which is now the settled upon name for monkeypox. It had slowed down to a pretty low level, and it seems to have taken a little bit of a turn again with an increase. And so we're monitoring that, and in particular, really focusing on people who had gotten a single dose of monkeypox vaccine at the point when, based on a shortage, we were recommending a single dose. We're now looping back and working to get people their second doses to maximize protection there. So that's kind of a lay of the land in terms of what's of most health concern right now. The other thing I wanted to use my update time for is just a little bit of a reflection on where we've come and some of the things that I think we've accomplished at OHA over the last 5 years. And if you'll indulge me a little bit of what I think I've learned along the way, or been reminded of. When I got here 5 years ago, you'll all, those of you who were on the board and probably others will recall, we were in a little bit of turmoil with lots of things kind of creeping up out of the woodwork that seemed to be surprises to people. There were transparency challenges. There were business processes that were, kind of off the rails, and it seemed like we were unaware of those kinds of things. And so really, my initial focus was the boring topic that I refer to as business rigor. How are we doing, and how do we know? How are we managing our processes? How do we keep from going from, as I said it at the time, green to yellow to red to dumpster fire? And because we had too many dumpster fires going on at the time. And we implemented a performance management system that I think really successfully did that and really looked at, and this is a system that we've reviewed a couple of times with the board, of what are we trying to accomplish? What are the areas that we need to generate outcomes for Oregonians in? What are the measures that tell us whether we're achieving those outcomes? What are the processes that we've established to do that work, and what's the health of those processes? Fundamental to that very first set of pieces of work that we did was taking health equity metrics, the demographic breakdowns of those health outcome measures, and not allowing them to be averaged up to green because they were buried in the overall population of the state, and really broke each socioeconomic and ethnic group out so that we would see those as top level measures. It gave us a ton of measures, but it also allowed us, or forced us, to really grapple with the fact that there was so much health inequity in the state. And this goes clear back to the first half of 2018 that we did that work. In a similar vein, we delayed CCO 2.0 by a year so that we could go back and do a fresh round of community engagement and really legitimately sit down with people and who are on the Oregon Health Plan and who work in communities served by the plan, and really talk authentically about what do we need to do to be able to have that system meet people's needs better. You'll recall the governor tasked the Health Policy Board with the 4 pillars of CCO 2.0, and together we worked on the idea of really changing the contracts for CCOs from a set of aspirational kinds of statements that were really not able to be enforced into, I think you ultimately picked 43 or 44 measurable items that you ultimately wanted to see in the contract. And the idea would be to move a dozen or so per year into the contract as we were able to measure and enforce those issues. Now, as we all know, the pandemic kind of sidetracked that structural issue, but that idea of holding CCOs accountable in ways that were meaningful and measurable, I think, was an important hallmark of the work that the agency and the Health Policy Board did to be able to make improvements in that area. And then, I think about some of the major initiatives that the agency has landed while in the pandemic. There are a bunch of them, but a couple I think strike me as just super important. One obviously is the waiver, and this waiver, I would say, unlike the previous waiver, has some really big deals that are in it. The investment in health-related social needs, especially housing. By itself, 6 months of housing assistance is not magic. And by itself, it's not going to solve any individual person's housing needs, but it's a really important transitional tool that will be able to get people off the streets into a stable environment where their co-occurring disorders, other behavioral health issues can be addressed and then can be packaged with other kinds of assistance to really make a meaningful difference. The other one I would draw attention to is the mergers and acquisitions regulation. I think the first few things out of the gate in that area have been pretty small, but they've been pretty important. The very first transaction, if I remember right, was a transaction of a venture capital firm getting into the hospice business. One very, very small impact in Oregon, one hospice program that was impacted by that, but it gave us a very early window into this notion of venture capital moving into a variety of healthcare or healthcare adjacent kinds of spaces that I think is going to become and is becoming a pretty significant national issue. And now we're going to see, I think, more significant transactions occurring as we move forward. And that program is well positioned to be able to provide Oregonians a meaningful voice, the only kind of a voice of its type in the country that I'm aware of right now that's got actual approval authority over those sorts of transactions. Two more things just I think to talk about. One, truly following the policy board's leadership is our ongoing commitment to health equity. The definition of health equity recommended to you by the Health Equity Committee and adopted by you and then adopted by the agency, I think has been just incredibly important. I often talk about, in particular, the idea embedded in that definition of allocating and reallocating power and resources as just being critical to the agency's thoughts and approach and how we've changed the work that we've done in a meaningful way around equity. Allocating and reallocating power, especially. Who's at the table? Who gets to decide? And shifting from, I think, a real typical government approach of all right, we're going to come up with a plan and then we're going to take our plan out to somebody and we're going to present our plan and they're going to make comments and maybe we'll listen to those comments and maybe we won't. Maybe we'll make changes and maybe we won't. And I'm not talking here specifically about OHA. I'm talking about just sort of government generally, whether it's state government or local government, that kind of a typical pattern to really changing that, to really wrestling with who's deciding, who actually has the power. And I've often said, if you think of this in terms of power sharing, you're doing it wrong, because power sharing implies that it's my power. And I'll let you be nearby while I exercise it. But it's my power, and really devolving power. And that's not even a great word. I guess I should take the word out of the definition. Reallocating power is so critical and so hard. And I'll come back to that in just a second. And then the last thing to mention, just because it's occupied so much over the last 2.5 years, almost 3 years now, is the pandemic. And if I ever questioned the wisdom of creating an Uber health agency like OHA is, uniting Medicaid and public health and behavioral health and health policy and regulation and all of the pieces that was really dispelled in the pandemic, where quite literally 5,000 people ran toward the fire. The ability to take every part of the organization and figure out how it could be used in an integrated way to address the greatest health threat in a century. And the job that not just the agency, but the governor through her leadership and Oregonians through their everyday actions, the organizational efforts by hospitals and local public health and hundreds of community-based organizations all working together to figure out how to keep us collectively, our community, safe. I think is a real testament to Oregonians' willingness to grapple with a problem and go do things that are practical and make a difference. And the net result of all of that is nearly the lowest infection rate in the country, one of the lower fatality rates, and the Commonwealth Fund found about a year ago that we had the 5th best pandemic response in the entire country, and I'm incredibly proud of that work. Just quickly to wrap up, I guess one of the things that one thing I was reminded of, and the other thing I learned what I was reminded of is the old saying that friends come and go, but enemies accumulate. I think you go do hard things and you're going to get people who are ticked off with the fact that you're doing hard things, and the more hard things you do, the more people are going to be ticked off. And I don't regret for a minute any of the hard things that we've tried to do. I kind of wish there hadn't been a pandemic in there, because I think we could have gotten more of those hard things done. But there's also good that's come out of the pandemic, and I'm grateful for that. The other thing I think that I have learned is, in fact, how truly hard delivering health equity actually is. I think about some areas where we really did a good job of reallocating power and resources. I think about our vaccine prioritization committee. I think about the Oversight and Accountability Council for Measure 110, and those were very messy processes. And that's okay, and that's good. But there's not a lot of tolerance for that. The media, pretty much broke into open mockery of the Vaccine Prioritization Committee's work. One of the points that I took a lot of heat for was the fact that there was someone who was pretty openly vaccine skeptical on that committee. And, the notion was, how on earth could you have somebody who was a vaccine skeptic involved in prioritizing vaccines? And the answer, I think, was pretty straightforward, which is, we're trying to vaccinate people who are vaccine skeptical. And so, having that perspective at the table, helping make decisions, is in fact really critically important, because we want to be able to talk to people who are vaccine skeptics and figure out what are the strategies that are going to answer their questions and make them less skeptical. And I think we did, in fact, a really good job. Ultimately, we achieved vaccine parity in Oregon, which I think a lot of people didn't think that we could do. We ended up with a vaccination rate for Black Oregonians that was the highest in the country for states that keep track of that data. And I'm extraordinarily proud, not just of us, but of all of the huge number of partners that we worked with to be able to achieve that. But it's really hard, and it's messy, and it takes longer, and you actually have to have tolerance and a little bit of political capital to be able to push back on that and try to deal with those issues. And so, I think to the next administration and to my successor at the agency, that would probably be the biggest advice, is really go in eyes wide open, knowing what you're going to need to do to deliver health equity, and that it is in fact going to be hard, and that there are going to be times when there are a lot of pressures that are also worthwhile pressures or objectives, or those kinds of things that are going to need to be paid attention to. And it's gonna take some strength to be able to push back and say, yeah, I know this is taking longer than you'd like, but it's really important that we do it this way so that what we have is an equitable outcome. So I'm really proud of the time that I've spent at OHA. Honestly, I'm gonna be sad or honestly, and maybe unbelievably for some people, I'm gonna be sad to leaving it behind. But think the agency is a different place, and I'm proud of that, and I know it'll serve Oregonians well that it is a different place. So with that, Chair Arana, back to you.
Thank you so much, Director Allen. And I could really relate to the comments about doing difficult and challenging work and picking up enemies along the way. So thank you so much for your fearless leadership over the last 5+ years. And I'd love to open it up to my fellow colleagues for any comments. Ebony.
So just again, want to take this opportunity, had a chance to briefly thank Pat Allen yesterday, Director Allen, but again, just publicly want to appreciate you and thank you because, you know, this work is thankless. You know, I appreciated so much of what you said in terms of being able to capture and surmise just where we've been to, you know, and that's going to be important for us to be grounded as we move forward so that we can sustain, you know, the successes and then bring on innovation and an enhancement. You know, I also think it's important, you know, I always say this and, you know, I don't know if folks agree with me or not, but this really speaks to what you said. You know, I always say that if everyone is happy with what is occurring or going on in terms of, you know, leadership and decisions made, then I'm a strong believer that then you do got to question, you know, where are you at? So I totally understand that not everyone's going to be happy, but it's about being bold. It's about being courageous and really being willing to kind of, you know, take us out of, you know, the box that, you know, we've been in, and you've definitely done that. And, you know, the last thing I just want to say, there's so many things I could say, but, you know, I truly do appreciate, you know, your fierce leadership and allyship, and also moving forward the health equity work, the service equity work, and the racial equity work. So thank you so much. You're going to be missed.
Thank you, Ebony. Brenda.
Yeah, it's always really great to follow Ebony. I concur. And I am so grateful having been on the receiving end of some of the health policy work that you've enacted and that you've led us through at a time during the pandemic when I'm glad you brought that up, Pat, when the vaccine distribution methodology was being talked about. And living in Southern Oregon and running a health center that primarily serves Latinx people in our community, what it would have been like had you not really taken those courageous efforts to try to understand the importance of distribution that really kept that population in mind. And so I think about, my goodness, over the years that you've been with us, how many lives have we saved as a result of that kind of leadership? Then what you talked about, 5,000 individuals inside the organization, you know, running toward the fire during the pandemic. I just imagine what that would have been like had you not been at the helm. So I remain supremely grateful for your leadership and support during the time. I think Ebony spoke well about the health equity work, and I hope our agency and our board can continue to stay the course and deepen the work that you've begun. So again, with deep gratitude, I wish you the very best in what's next.
Thank you, Brenda. John?
Yeah, well, Pat, terrific comments. It's hard to improve on what you said. So what I'll do is, you know, reinforce them. I'm not the longest serving person on the board here today, but I would certainly acknowledge that when I came, things were messy. And, you know, your arrival from a business point of view really did make a difference. And that, you know, a couple of years after your arrival, it was pretty clear that was working. And that was really an incredible accomplishment. I think the pandemic was a career changer, a life changer for a lot of us. And as an older person, you know, it was folks my age who were dying. And I think the, you know, several thousand lives that were saved in Oregon are predominantly seniors. And, you know, it's hard enough being 70 and seeing people go here and there. And I'm glad I'm in a state where I missed some of that. There's a lot of my friends and acquaintances that I think are healthier or alive today because of what Oregon did. And I appreciate that. You didn't mention your communication skills, but I think you really have superb communication skills, both written and verbal. And I really appreciate that. And, you know, I think as a leader, you set an example. Again, those trips we had, I'll never forget going to the Umatilla reservation and those 3 days. And you know, it was really an example of superb communications. You know, finally, I think your willingness to set priorities that were challenging were unique. A lot of folks wouldn't do that, or they'd figure out how to have somebody else set those priorities and not be on the point. You know, during the peak of the pandemic, had lots of time on my hands, and every day I would take the immunization data and put it in my own Excel spreadsheet. And I remember starting to see the rate of immunization in African Americans and Hispanics started to rise. Every day, that rate rose. Every day for months. And you know, that's an incredible accomplishment. And I hope that however you all did that is available for other public health folks in other states to look at, because that was incredible to see. Just from a numbers and statistical point of view, it is a real accomplishment. I would just end by saying, you know, early in my career, I remember sitting down to talk and get advice from a person more senior. And he said, well, John, you've taken a job where you're on the point. And, you know, during the pandemic, I think you agreed to be on point. And you know what happens when you're the point person is a lot of times you don't survive, you die. And that's what he said. You know, when you're on the point, it's like you either die or you get the Medal of Honor. Sometimes you get both. And I think you're in the category where you get both. You're not going to get the Medal of Honor from, you know, any formal process, but you got my Medal of Honor. Thanks.
Thanks, John. I just have to quickly comment. I enjoyed those trips as well. My recollection, though, was of the Lakeview trip where sort of it dawned on us that a government agency controls the hospital and the local clinic and the long-term care facility and public health and behavioral health. And it sort of I realized that they have British style socialized medicine in Lakeview, Oregon, and I don't think they actually even realize it locally. That was a revelation.
I agree. That was they were all incredible, and a lot of it I think is you were there, and you know when the top guy's there, people are talking. You know, people are paying attention. People are coming, and that was incredible to see. Thank you for coming. Not only letting us do it, but for coming.
Thank you, John. Bill?
Hi, Pat. Thanks very much for your service to the people of Oregon. I've only been on the board for a year and a half, so I've only seen the latter part of your time at the Oregon Health Authority. But I've been so impressed. I believe you're a real model of public service. Your calm professionalism has been evident, both through the direct evidence that I see of the accomplishments of the Oregon Health Authority and the state of Oregon in general and on these very difficult and challenging issues. Your monthly updates to the board have been exceptionally helpful, informative, and clear. but also the indirect effects that I see, that I know you must be having throughout the agency, because your calm professionalism, commitment to values, and to visionary goals is suffused throughout the organization with almost everybody I interact with at the Oregon Health Authority. So your impact not only has been felt the last 5 years, but will be felt for years afterwards with the folks you have recruited and been a model for. So this has been a very, very difficult time for everyone in Oregon. The health issues we face, the crises we faced have been very difficult. And you provided steady, calm leadership, and the state is better off because of all the tremendous work you've done. Thank you so much.
Thank you, Bill. Kristen.
Well, with so much wonderful things said by fellow board members, again, ditto to it all. I too would give you the medal to whatever. Medals tend to be made out of yogurt lids in our house with a ribbon, but I will make you one, Director Allen. I just, yes, ditto to what everyone said. I think there's something about honoring the real leadership that you had in setting challenging priorities, to use Don Santa's words, and that just what an amazing gift to our state and all of us who live in it, that you did that. And when I think about the example you set as a leader and as a public servant, it's not just that you set those challenging priorities and had the courage to do that and stick with them. It's that it's accompanied with this humble openness. So you have this vision, and you say let's tackle that really hard thing. And while we're doing it, let's reflect and learn and listen. And what more could we ask for? And I think that really is an example that we can all take with us and are all so lucky to have been part of, and is why I think, what better leader would you rather run into a fire with than that? So with deep, deep gratitude, thank you for your service and all that you leave us with, and may you enjoy retirement. And if you get back to reffing basketball, which I heard at some point you do, I hope to see you on the courts. So thank you so much.
Thanks, Kirsten. I'm not sure getting back on the courts in the future, but I'm also not ready to sit home and watch Matlock. So hopefully I'm on to the next adventure that maybe is a little less adventurous.
Thank you, Kirsten. Oh, Sandy, go ahead.
Yeah, I just got on. I mean, being able to talk. So thank you, Pat. I remember our first meeting in Klamath Falls, Oregon, and sitting down and discussing the relationships with tribal organizations. And you're just stellar at everything that you have done for the Oregon Health Authority, Medicaid, working with DHS, and maybe we didn't get to CCO 2.0, but I do appreciate all your time with the Oregon Health Authority since I've met you. So I just want to wish you the best, and I'm sure we'll see you somewhere down the road here in a different capacity that you'll strive at making things wonderful like you've done over the last 5-6 years. So thank you so much.
Thanks, Sandy. I also really remember that first meeting in Klamath Falls, and like a lot of things, OHA's relationship with tribes was pretty rocky. And I remember sitting down with you on a break and saying, we got to do better, and we are going to do better. And with Julie Johnson's leadership, and with a lot of patience and work from the tribes, I think we did make things better. And one of the things we tried to do was figure out how to get out of the tribes way, as they tried to meet the needs of their members in terms of health. One of the big ones I remember, and I think you do too, Sandy, was around tribal practices around diabetes prevention and treatment, and how we, for a long period of time at the agency, had really tried to force tribes to fit a square peg into a round hole and try to figure out how to make those tribal practices fit what we said they needed to be. And I think we finally got to a place where we kind of stepped back, and like a lot of things with health equity, we're able to say, let's listen to community and do what they're telling us they want to do. And today I'm really proud of the fact that, as an example, the Cow Creek clinics in Douglas County are the community center for diabetes prevention and treatment, not just for tribal members, but for the community at large. And I think that's a huge testament to the tribe's great work in meeting their community's needs and what we can accomplish if we at the agency just shut up and listen and get out of the way.
Thank you so much. You've been an asset to tribal organizations, so we wish you well.
Thank you so much, Sandy. Any last words from my fellow board members for Director Allen? Well, there's not much more I can add. I just really want to thank you again for your courageous leadership during this very challenging time. I want to also thank you for not only did you lean into the pandemic response, you also really leaned into the health equity definition and really worked to apply it as an agency. I think I keep hearing you sort of reflecting on the redistribution of power and resources, and I could really see OHA doing that over the last few years at a very critical moment during this pandemic. So thank you again for all your work. And yes, we know you are going to do other amazing things. I just hope that it's here for the state of Oregon. And if not, that at least it has an impact in the state of Oregon. So I hope I hope our professional paths get to cross again in the future. So
Thank you, Chair Rana, and everyone else for such very gracious comments. They're very humbling. Thank you.
All right, so we are going to transition now to our next agenda item. We have staff from OHA and ODHS who are going to provide an update on the post-public health emergency eligibility renewals. And I think we are having some new staff present on this topic. So I'm going to let them introduce themselves and let them take it away.
Hi, my name is Hildy Hinkle, and my pronouns are she, her, hers. I support Sarah Dobra, who is unexpectedly out today, with supporting the community and partner work group. So I will be presenting in her place, and also my colleague Jillian Johnson will be presenting with me as well. So do we have a slide deck? Great, thank you so much. So I will begin with an update on the community and partner work group and how their work has informed and influenced our approach to the public health emergency unwinding. Then I will turn the presentation over to Jillian, who will discuss infrastructure and systems improvements, also in preparation for the end of the federal public health emergency. Next slide, please. Next slide. So in addition to getting up to speed on the public health emergency unwinding and related efforts to support people receiving benefits, The community and partner work group has spent significant time understanding the complexities of the Medicaid renewal process in order to complete recommendations for when populations should be scheduled for renewal based on risk factors. The work group has also provided valuable input on communications planning, tools to support partners and providers, and strategies to overcome known barriers to outreach and communication. Next slide, please. So I won't go over this slide in detail again, since this information was presented last month. I just want to note that the community and partner work group has been having in-depth conversations about population sequencing since the summer and made final recommendations in October. Next slide. So the work group is still in the process of making recommendations, and the work group members have identified several topics to prioritize. Since the work group concluded discussions on sequencing, they have had a strong focus on making recommendations for outreach and communications to populations with known barriers or disadvantages, including unhoused populations, members who prefer language other than English, and members with disabilities, among others. As you can see on the schedule, the work group is also providing input on paid outreach strategies, and we'll be discussing ex parte renewals next month. Next slide, please. So this slide provides examples of a more nuanced sequencing recommendation that is being incorporated, as well as recommendations the work group has made on outreach strategies. Other recommendations are requiring more planning and consideration by the agency. So House Bill 4035 states that recommendations should be within the authority's legislatively approved budget. So the agency does need to assess whether recommendations meet this requirement. So for example, the community and partner work group recommended funding homeless service providers to assist with redeterminations and funding CBOs to conduct outreach and application assistance events in multiple languages. So these strategies would likely require funding beyond the approved budget. However, the agency may be able to accomplish these recommendations in more limited ways. For example, through the paid media campaign that will provide, or the paid outreach campaign that would provide limited funds to a limited number of organizations to assist with outreach. The report to the legislature is due March 1st, so the work group will wrap up recommendations in early February, and we'll have an overall picture of recommendations within the budget and how those are being implemented. Next slide, please. And I will turn this over to Jillian.
Thank you, Hildy. I appreciate it. Hi, Jillian Johnson, she, her, hers. I am with the Oregon Department of Human Services with the Oregon Eligibility Partnership. It is nice to see your faces again. When I was here joining you last month, we talked a little bit about the public health emergency unwinding and what was expected in terms of our ability to timely serve Oregonians, and really sort of talked about the realities of the workload. I'll give updates on that briefly, but first I want to sort of give some additional information about process improvements and efficiencies that have been put into place that are really geared at supporting people with more options, streamlining things, providing better customer service, and also really giving more self-service options for people who want to get in their information and don't necessarily need to talk to an individual. So 2 of these are live right now. And I think this slide has those things that come up as you talk about them. But it's okay if all 5 just show up, y'all. language access lines and a callback option are both now live. And those are the first two listed on the slide there. Language access lines are really the one customer service center now offers interpretation services in 16 different languages through different dedicated 1-800 access lines. So previously, those interpreted services were really limited to English, Spanish, Russian, and Vietnamese. So that has been expanded. And when they use that system, they're greeted in their chosen language, paired with an interpreter, and connected more quickly to a eligibility worker to help reduce those barriers to sort of waiting on hold, being with an interpreter, all of those types of things. And that allows us to better serve those Oregonians. The callback option is for the one customer service center. And basically, instead of waiting on hold for an extended period of time, callers can select an option for a callback when they come up in the queue, and it gives them sort of an estimated time frame, et cetera. Right now, that is only for the English eligibility queue, and that is because the wait time for the queues that support those other languages is less than 5 minutes at this time. The queue is also configurable, so depending on how long Oregonians have to wait, if it's less than 15 minutes, which is still an enormous, too much time, but if it is less than 15 minutes, the callback option won't be activated. We're working towards robotic process automation. It is really a process that allows us to automate our return mail process, which will reduce the workload and reallocate time. And it would include sort of identifying return mail and notices received, and then reaching out to the applicants by their preferred method of contact. And that's going to include text, voicemail, and email options. We're also moving towards implementation of interactive voice response. So once again, this is a more self-service option. If you want to call and just gain information and be able to, do anything that might not necessarily need to talk to an in-person worker, then this would allow people to circumvent the hold time, and just sort of continue. And then the one mobile app. So right now, the one eligibility system really isn't super accessible outside of a PC, and that's a huge barrier. Most folks access the internet on their mobile devices, and so implementation of this will really increase that accessibility. And I lost my place, I apologize. It'll come out in 2 parts, but that should be coming this spring. So hopefully in time with the unwinding of the public health emergency, or in time for it to be extended again. And then briefly, we'll go over the next couple slides, which is really just more about our current workload. And so this is a slide that sort of pictures the state of applications that are received. The goal is to process applications the day they're received or the next day. We're hanging out around 43% on that. It really shows our progression and our ability to meet that goal over the past 18 or so months. And this is a time period where many public health emergency protections are in place, and that helps us sort of gain an understanding of what might happen when the public health emergency ends, because there's dips in, say, July of 2022 that coincide with the ending of certain public health emergency food benefit protections. We'll go to the next slide. Processing wait times. This is consistent with what we've been reporting out. Processing wait times mean that we are outside of the federal guidelines. And so as of last Friday, we had over 5,500 applications that are past those deadlines. And around 3,200 of those are pending worker action. So they're not waiting for action from the Oregonian, they're waiting for action for ODHS. And then the next slide.
Sorry
really,
for interrupting, Jillian. Do you mind
Yes.
repeating what you just said again? What percentage are awaiting worker action?
let me do the percentage for you. Hold on, I'm going to bring up a calculator.
Or just what you said again.
It's 3,249 out of 5,659. So about 57% of the applications that are past federal processing timeframes are waiting on action by ODHS workers.
Thank you so much.
You're super welcome. All right, and then the phone wait times. So this is where we're at with some recent data. I don't have today's data, apologies for that. The average wait time is 15 minutes and 18 minutes, which means that a lot of folks end up speaking with a support staff worker first and then end up going to an eligibility worker because they might not exactly know what they need. And so really a typical experience would be adding those together. However, it's really important also that we're reporting on those maximum wait times, because one person waiting more than 2 hours, I mean, it's ridiculous. It is unacceptable, and nobody likes where this is at. The reality is that our staffing hasn't kept up with the demand for the assistance, and despite the innovations that we're putting in place to help improve those experiences, this is our current reality. And so, that's why when possible, we're trying to encourage folks to, use other ways for submitting information, right? Like doing things online, et cetera. However, also recognizing that in and of itself is a huge barrier for a majority of the people we serve. If you're interested in seeing the data and the reports that are put up, those operational reports are on benefits.oregon.gov, and there's a link over to the new One Eligibility System information page that contains that data. It's also where the House Bill 4035 live dashboard, that'll be an external dashboard, that's where that will live. And when that dashboard is up, we're hoping to come back to you in the new year with a live demo of that dashboard. And so we can go to the next slide. This is really more about innovations that have been implemented. What I would like to do, though, is, you all received this. You can look and see more about the different innovations and different things that we've been implementing to try to help with workload. But I want to really make sure that there's time for discussion and questions, and that leaves us about 5 minutes or so on the agenda. You're also always welcome to reach out to me directly if you have specific questions. I'll put my email in the chat around what are you doing and why, and there's one question around staff and the availability of staff to speak the languages that people are calling in with. We do have staff that speak a number of different languages, And one of the things that I am advocating for and we're looking at is really the ability to directly route callers based on the language they speak, right? To a worker who might be available who can speak that language, because interpreters are good for accessibility, but they're not the ideal, right? Because the language we speak around Medicaid and food benefits is very specific language, and that can be hard to translate. And so working on hiring folks with different languages is critical, but also improving our system and getting the funding to be able to pay for those enhancements. And that's a huge barrier to doing a lot of the things that we'd like to see done. So Stick, I hope that answers your question. And I'll stop there.
Thank you, Jillian. Were there additional slides that were going to be presented by Hildy or anybody else?
No, no.
Okay.
That was all.
I will open it up for questions. Brenda.
I have a question. Thank you so much for that presentation. It's very helpful. And I appreciate the honesty and transparency around the stuck points. I think that's really important information for many, many people to understand. My question is related to a slide that wasn't covered, so I apologize if this wasn't your goal, but it's specifically around the returned mail function. So I noticed about 65,000 in your slide deck. Notices have gone out. You're working with coordinated care organizations to ensure that we can reach people as much as possible. And I could take this offline. I'm thinking specifically about other data transfer opportunities among health centers, in the state of Oregon, who have a lot of relationship with these very populations in our public health departments, and how organizations like OCHIN, for example, that manages a lot of the data and has more accurate addresses perhaps than what we have through the one system or through CCOs, might be able to be accessed and help, because that's also an incredible volume of people who we may have better information about. So I guess that's a comment more than a question, but happy to brainstorm offline if that's helpful.
Absolutely. I think that's a really valuable comment. And when we're looking at this type of information, one of the big things is that we had to get a waiver from CMS to be able to specifically even do the updates with the managed care organizations. And so that, of course, is its own barrier in and of itself. But I am certain that, ideas and, ways to sort of overcome those barriers are incredibly welcome. I love that thinking. Thank you, Brenda.
Other questions or comments from board members? Kirsten.
I just, I appreciate the recognition that there's still a lot more work to do, but just because this work is hard, I just want to call out how exciting it is to see the callback and not wait on hold option online. That is huge. And so lovely to see that implemented after it kind of being in the works for a long time. So great to hear that news. And I think having the one mobile system come online in the spring, ideally before this redetermination process really goes in full swing, is also an excellent move. That is really how adults access the internet these days. And so I'm excited to see that on the books as well. There are challenges that remain, and I appreciate those working through them. Could you say a little bit more about, I mean, I think it's great. I appreciate the honesty in calling out the like, these are the applications that haven't moved. And that it's waiting on staff for the next move, not the applicant. Could you say a little bit more about the challenges behind that? And if there's any expected movement, or are we stuck?
You know, the reality is that our workload has increased by a third without new staffing. And so, you know, we're stuck, right? And we're in a place where we're trying to decide who has the highest priority of all these people that are reaching out and needing supports. It's a terrible place to be in. And, you know, and so that's really why my presentation is like, look, we're trying these great things and this is cool. And this is where we're at, because we know this is where we're at given pandemic, given public health emergency protections. And so, you know, we're hopeful, but even if, say, you know, in, you know, this winter during session, let's say we're going to get some position authority and we can increase our eligibility workload, that takes time and in a very challenging labor market. And, you know, the state of Oregon doesn't appear to have the pull of a premier employer that maybe it did years ago. So there's just a lot of different challenges around, you know, even with those positions, how do you fill them, train them so that they can support people quickly? You know, one of the things I didn't mention, and I know we're getting close on time or we're over, so apologies. I just love to engage. One of the things that we're also doing is we're contracted with a vendor called PH Tech, and they've been doing different types of supports. And one of the supports that has been really critical beyond the returned mail supports that they were doing and that sort of Brenda referenced is that they're helping with the calls to the one eligibility center, to the one customer service center. And just this week, they're starting to talk to individuals who might just have, you know, sort of some basic updates so that we can really move things forward differently. So we'll be tracking data around that and seeing what type of impact that makes in terms of Oregonian wait times and experiences. And thank you, Kristen, for also championing the positives there. I appreciate that.
Any other questions or comments from the board? Well, thank you so much, Jillian and Hildy, for your presentation today and these monthly progress updates. I think what could be really useful for future, like, you know, either next month or the month after, just really a presentation of kind of outlining where are the like challenges that you're describing, right? I think we're familiar with them about sort of like staffing, lack of staffing, additional needing more capacity. So really kind of like bottom lining those and potentially providing recommendations of what could be done or how the board could support moving any of those forward. So thank you again and appreciate you stepping in to take over other presenters today. All right, so next we are going to welcome Jeff Scroggin, OHA's Interim Director of Government Relations. Today, Jeff is going to share some updates on the 2023 legislative session. So Jeff, go ahead and take it away.
Thanks, Chair. Tara, I think there's some slides to pop up here. Oh, yep, and here they are. Next slide, please. So this is the first slide. I am going to spend some time here. I know that we went through earlier Pat's transition. I should note I'm also leaving the agency. December 16th is going to be my last day at work. And the interim director for government relations going forward will be Ashley Thurstrup, and you can see her contact information on this slide. Ashley's great. She has a robust experience in public health and is one of our leaders in our interfacing and liaising with the Office of Department of Education. So I'm really excited for what she's going to be able to bring to the government relations team as the new interim director. And then I also want to share that we've brought on a senior policy advisor for behavioral health, Kaz Zaidi. Kaz this is his first day with a phone and an email address, so we have to update that information. He's brand new, so you'll probably be hearing more from him as he gets comfortable in his seat as the new senior policy advisor for behavioral health and government relations. Next slide. I was asked to share what the governor-elect's priorities were going to be or what her plans were for healthcare. So I'm going to preface that with saying the governor-elect is in transition. So we haven't gotten that information yet directly from the governor-elect. She's the governor-elect and not the governor yet. So what I did was, and I'm sorry this isn't very much, went over to her website, which you can see cited on the bottom of this slide, and just copy and pasted over there what she used in her campaign as her priorities. And I have them up on some slides to share here today. I do, the governor-elect's transition team is moving forward full steam ahead, and the transition is moving forward. We hear from them. I think seeing the governor-elect's budget priorities is going to be a really clear first indicator of her priorities as she takes office, and would welcome the board to kind of keep going down this vein as the transition team moves forward with one of the big major next steps for the governor-elect, which will be putting out a budget, a governor's recommended budget. So here we have some of the priorities from the governor-elect: transforming and training for police and security officers to meet international standards, investing in our community-based organizations, building a workforce development pipeline for underserved communities, guaranteeing economic development initiatives for all people in Oregon. Next slide. If you ask me questions about this, especially from the perspective of what is the governor's plan, I'm not going to have an answer for you. I'm just going to go out there and say that right now. I think we have to give her and her team some time to transition into the office before we can see what exact levers she's intending to pull at the bureaucratic state level, the agency level. We know that improving Oregon's behavioral health system is a priority for the governor-elect, specifically expanding inpatient and outpatient services, helping people who are experiencing houselessness and suffering from mental health or substance use disorder, eliminating the red tape in government insurance bureaucracies that prevent people in Oregon from accessing treatment, investing in diverse behavioral health workforce, and ensuring access to services that promote social and emotional wellness. Next slide. Housing is another, right along with behavioral health, rise to the top priority, it seems, and ending unsheltered homelessness for veterans and families with children and unaccompanied young adults and people 65 years or older. She set a goal here by 2025. Building enough housing to meet the need for people currently experiencing homelessness, advancing racial equity by reducing racial homeownership gap, keeping people housed who are currently on the brink of homelessness, and encouraging intergovernmental and private sector partnerships to have more effective and efficient responses. And like I mentioned earlier, I expect the governor's coming budget to kind of reflect these priorities in action. And I think that will help answer some of the initial questions, at least, about, what does this translate into as far as OHA's role? Next slide. Here's healthcare and public health specifically, protecting progress and reducing the number of uninsured or people in Oregon, maintaining and increasing access to care in rural communities, strengthening Oregon's public health system, investing in diverse healthcare workforce, and continuing to move healthcare dollars upstream for prevention by investing in social determinants of health and leveraging federal dollars. Next slide. Women's rights and defending reproductive freedom is on the list, ensuring that Oregon is a safe harbor for anyone seeking access to reproductive health, addressing systematic inequities within our healthcare system, and investing in comprehensive medically accurate education. Next slide. The rest of the slides you've seen versions of before, and they're updates on OHA's legislative agenda. We're still, looking forward to working with the transition team and the governor-elect on what her priorities and how they influence our agenda will be. I will say that I think that our agenda is in pretty good shape for the governor-elect. I think a lot of the priorities that I just shared are aligned with the agency's priorities. I've shared these themes with you before, but building health equity infrastructure and implementing health equity is a top line priority for the state in our legislative agenda. And we have some others here: building a post-pandemic public health system, state hospital operations, the Oregon State Hospital, Medicaid and behavioral health system accountability, implementation of that new 1115 waiver and health policy improvements, and then other housekeeping and mandated bills. Next slide. So we have a whole slew of slides here on proposed major legislation and POPs. One is around confidentiality for REALD and SOGI data. Another is around lowering barriers to committee membership for advisory committees. And this is something I think the board has explored before. One of the things we're doing is trying to go out pretty flexible and broad about having the authority within the authority to help people compensate people appropriately on their committees. And I think the reason we need some flexibility is, frankly, that's different for different committees and different people. And having a one-size-fits-all approach just isn't working. Some folks don't want to receive some compensation. Some folks want to receive a certain amount of compensation. Some folks want to receive compensation in a certain way. And so I think one of the things we're chasing here is a little more flexibility in how we compensate folks as a first step to breaking down those barriers. Next slide. Some major public health legislation. We briefed all of these before. I think there's the flavored tobacco and synthetic nicotine LC is one I would point you to as one that's going to be a lift. It's always a lift, but I think with some things that have happened in Oregon already that the time is right for this, and we're going to pursue it. Next slide. Major legislation for the Health Policy and Analytics Division and Health Systems Division include moving to a state-based marketplace for our Oregon Health Insurance Marketplace. Right now, we use the federal technology, which means we don't have any flexibility to focus on special populations or projects or do things like special enrollment periods. Also, largely in this space is Medicaid waiver implementation. Talked a little bit about that in the themes, and I'm sure you've been briefed several times on the waiver, but implementation of that's a priority for the agency, and we have a bill for some of the statutory changes, like the incentive committee structure to match up with what was negotiated in the waiver. And then there's a legislative concept related to redeterminations, which is a placeholder for House Bill 4035, which also includes that basic health plan component. Next slide. Major behavioral health legislation, a lot going on in the state hospital and assist, and then an LC 502 related to payer parity in the behavioral health crisis services space. And the concept here really is insurance should also cover behavioral health crisis services. Right now, it seems that the state is really on the hook to cover these services. And if you have insurance and you have a behavioral health crisis, we want to make sure that the law is clear that those services should be covered by your insurance as well. Next slide. This is all of our concepts. I ran through some of the highlight ones and just highlighted some of the highlights on the slide, actually. These are all of them with the short title. And our website also has every single concept publicly, transparently posted. We really appreciate using the board as the venue to post all those previously, but we did it on our own website this time around. Next slide. So that there wasn't a whole packet full of LCs for you all. Now I'm going to transition to budget requests, policy option packages. These are in general funds. There's usually for some of them other funds associated or federal funds. And you can see all that level of detail again on the OHAGR website and find all the federal funds, other funds that are associated with each one of these asks, as well as summary and deeper information. We have a POP to work on the infrastructure to keep working on the agency's 2030 goal of eliminating health inequities. We have some other POPs around regional health equity coalition expansion. We really believe the RHEC model has been very helpful to centering community voice and underserved populations in community, and looking to fund a second phase of the RHEC model. Next slide. Some major public health budget requests. I'll point to by far the biggest one on this slide, which is public health modernization. We have a fairly large ask in here for public health modernization, but when folks ask, what are we going to do about the cliff that's coming with the public health emergency going away, one of our answers is public health modernization. A lot of what we learned in the pandemic and what we're still learning, we need to apply with tools and financial investment. So we have a large ask here to keep going with public health modernization. Next slide. We have some TBD numbers around some of the health policy analytics and health system division budget requests. The Medicaid waiver, we're still working on those numbers. It's a large investment by the federal government. There is going to be some investment by the state, but I think that the billion or more back that we got from the feds should more than balance that. And then redeterminations in the basic health program, that work is still being developed in consultation with the task force that the legislation stood up. Next slide. Major behavioral health budget requests. The major big one here I'll point to is the expansion of the 988 crisis system. When you call 988, we need to make sure that there is capacity for the crisis system to meet standards and to have facilities and people to answer the phone. So one of our, top 3 or 4 biggest asks is to continue building out that 988 system, so that's not, kind of a phone call to nowhere. We will have several budget asks related to the state hospital, and we've got one listed here, which is around the sustainable staffing plan, which was developed under House Bill 5024. Next slide. This is all of the budget requests. Next slide. There's 2 sheets of them. There's a lot of budget requests. And again, you're welcome to go to our website. I ran through that all really fast. I think it's all information that we've shared with you before, so I didn't feel like we should go through it in depth and wanted to leave time for any questions. This is the website that I kept mentioning over and over again. I'm really proud of this. We have, like I said, all of our stuff up early and transparently in the process. So everyone's welcome to go check out that website. There's also phone numbers and emails for who to contact if you have any questions about any concept. I think that's it. Yes, happy to answer any questions.
Thank you, Jeff. Looks like Bill has a question. Go ahead, Bill.
Thanks, Jeff. Appreciate all the information you shared. Appreciate your work you've done in this role, and best of luck going forward. I think these legislative themes make a lot of sense, and the budget requests as well. The emphasis on equity, strengthening public health system, mental and behavioral health services, the waiver, and so on, all makes sense. But one thing that seemed to be missing was stuff around cost and affordability. I know that has been a theme in the past, and there have been some legislation, of course, passed to address the issue of affordability and costs. I just wondered if that was where that came up in the discussions about what the legislature's interested in, what the new governor's interested in, what the agency's interested in, and just seemed conspicuous in its absence. Appreciate any comments you have about the affordability issue.
Yeah, happy to say a couple words. Thanks, Mr. Kramer. I think that we're on the implementation side of a large part of that work because of the cost growth target work. So and that's the major vehicle that I think legislatively we've been working on for the past few sessions around monitoring cost growth and having tools to address it. So I think the reason why you're not seeing legislation from us on that in that space is we kind of have a good portion of those tools. And I think right now we're looking at, what does implementation look like? When do we start having some of those hearings that we talked about? When are we going to start using some of those tools? And so I know that the program's working on that really hard. And I'm sure you will and have heard many updates from Sarah Bartleman and her team about cost growth target next steps. But I would point you there for more on affordability and defer to any other agency folks that might have any other comments.
Great, that makes sense. And I anticipated that was that may be where we are. So the emphasis needs to be continued on implementation, less to do in the legislative arena. Thanks a lot.
I do think we're going to be looking at, and getting a little weedy here, I think everyone, the agency, systems, businesses, people, and workers are all going to be talking about workforce and the workforce shortage and crisis and the impacts of that crisis, including on costs and affordability.
Thank you, Jeff. Any other questions for Jeff? Well, Jeff, thank you so much for your presentation and for everything you've done at OHA. Sad to hear that you're also going to be transitioning from the agency, but I'm sure you will also be moving on to do some really incredible things. So just want to say, you were critical in helping with my onboarding, so I really appreciate everything you did with that. I know you were a critical leader within supporting the Oregon Health Policy Board in the past, and you've done an incredible job leading the government relations team. So thank you so much for all your work at OHA. Really appreciate everything.
Thanks, Chair. Appreciate it.
Maybe I know that you also helped Tara Cheetog on board, particularly during the pandemic. So I'm going to give her an opportunity to say some comments for you as well.
Thanks, Oscar. And Jeff, thank you so much. When I took over the board, I think I had a couple of days noticed in June, and you were going to be out for an extended period of time. But I just wanted to say that you've always been a thought partner. You've always supported me, and you have such great line of sight into making policy connections and supporting the board. And I could not have done this job without you. And I'm very sad, and I will miss you. And I hope that we are connected, working together with OHA and the board in some way in the future. But truly, you are remarkable. Enjoy your time away. You will be missed.
I try really hard not to be surprised. It's like part of my job not to be surprised. So that was good. Good job, y'all.
Well, thank you. And thanks, Tara, for letting me put you on the spot. And one last comment I'll say is, I actually worked with Ashley Thurstrup at NEA here when she was a manager and a director here as well. So I am excited to see her step into your big shoes to fill, Jeff. So I know that she will do a great job as well. So happy to see her name show up as the next interim government relations director. All right, we are going to move into public comments, which I believe we might have two folks who have public comments to offer. So the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the thoughtful attention, respect, and honor that you deserve. Public comments are meant to provide everyone an opportunity to share their perspective and be heard. However, public comments are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and if that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate with the public speaker about next steps. So I believe Dan Cushing is here to provide public testimony. So Dan, go ahead and take it away.
Good morning, Chair Arana, members of the board. My name is Dan Cushing. I'm with you today on behalf of Coalition for a Healthy Oregon. COHO is an association of 7 of the state's coordinated care organizations serving more than 300,000 members of the Oregon Health Plan. My comments today are about the CCO 2.0 progress update that was shared at your last board meeting. I want to echo what Mr. Embody and Ms. Demars pointed out, that the COVID pandemic really got in the way, not just of CCO's ability to implement changes, but also OHA's ability to make those changes possible through rules and contract changes. But with that said, we should all be proud of the changes that were made in line with the board's vision for CCO 2.0, including investments in the social determinants of health and health equity. A few considerations that we'd like to share with you from the CCO perspective about CCO 2.0 as you look to the next contract phase. Number one, our experience with CCO 2.0 is a significant increase in administrative reporting. Now, the number of deliverables that CCOs have to provide to OHA has increased to the point where now CCOs have a report due to OHA nearly every other business day. We urge the Oregon Health Policy Board to direct OHA to change its approach away from process and more toward member outcomes to the extent possible. Number two, CCOs have been working locally on solutions to the behavioral health crisis, but these challenges are bigger than CCOs alone can solve. We believe a statewide effort is needed to address workforce and other issues, and we are ready to be at that table, focusing on solutions. And then finally, investing in the social determinants of health and equity is a top priority for us, but the funding mechanisms that are allowed by our contracts and by our systems are still misaligned. So as CCOs, we continue to advocate for better strategies that will really improve the well-being of our communities. And with that, I'd like to point you to the letter that was submitted for your meeting materials, and I thank you for the opportunity to speak.
Thank you, Dan, for the letter and for your public comments today. We will follow up next week. All right, Tom Bussey is next. Tom? Tom, we cannot hear you, unfortunately. There might be something going on with your audio, but we cannot hear your comments. Why don't we do this? Why don't we go on a brief break, and then we will, during the break, we will try to troubleshoot with Tom, and let's come back at 10:10 a.m. To continue the meeting. Sounds good. We'll take a break, and then we will troubleshoot and come back. And my fellow board members, if I can just get like a thumbs up or turn on your video so I know you are back. All right, we are going to resume our meeting. Just really quickly, Tara and Madeline, I wanted to make sure that we captured that Kirsten wants to abstain from the accepting of the November meeting minutes because she was not here last month. And finally, did we get Tom Bussey back yet?
He has not logged back into the meeting, so we'll continue to connect with him over email.
Sounds good. We're going to move into our next agenda item, which is a presentation from the Health Equity Committee. So OHPB's Health Equity Committee co-chairs, Jorge Ramirez Garcia and Stick Crosby, along with OHA's Director of Equity and Inclusion, Leanne Johnson, join us today to provide committee updates and seek a vote of approval on its proposed committee membership slate. Thank you for being here today to present, and thank you and all your colleagues and committee members for all you do to help align and integrate health equity into the agency. Please begin when you are ready.
All right. Thank you, Chair Arana. Leanne Johnson, Director of the Equity and Inclusion Division. She, her are my pronouns. And I know we have a slideshow, and I also want to acknowledge and introduce my colleagues today, the co-chairs of the Health Equity Committee, Jorge Ramirez Garcia and Stick Crosby, who will also be presenting today. I will start, and then I will turn the agenda over to them to finish up our presentation today. We appreciate being here. We appreciate your ongoing support of health equity, and it goes beyond support. It is demonstrated in all that you are doing, and that is showing up in many ways throughout the state, and that is changing the course of health outcomes for people in our state. So thank you very much for your commitment. Next slide, please. So just to a refresh reminder, and also I understand we have a new member today, so welcome. The Health Equity Committee was established in 2017 by the Oregon Health Policy Board. It actually was a pickup of work that had been done previously, and we're very appreciative that in 2017 we had the opportunity to establish a a committee of this nature to provide advice and guidance and leadership as it relates to health equity in the health system. And the purpose of that committee is to both coordinate and develop policy that proactively promotes the elimination of health inequities and the opportunity to achieve health equity for all people in the state of Oregon. Next slide, please. So as pointed out by Director Pat Allen, as one of the accomplishments is the development and adoption of the health equity definition, and also deep appreciation for the leadership around this work. And what I just want to point out some very critical aspects of this definition for those who haven't had a chance to interact much with it. But what is very important in the opening part is that it speaks to what the vision is, and that vision and mission is for all people in the state of Oregon to achieve their full health potential. And that's not simply the absence of disease, that means well-being at every level. And we understand that in our state and in our society and in our nation, that inequities, racism, oppression, and a variety of other barriers, including long-standing colonization of our systems dating back 530 years, have had an ongoing and continued and contemporary impact on health outcomes. So we talk about and have an action plan around achieving health equity because in this definition, it is inherent, action is inherent. And that begins with ongoing collaboration throughout the state, throughout all regions and sectors, and very importantly, includes honoring the government-to-government sovereign nation status of the 9 federally recognized tribes, tribal governments. And so working together, we are seeking the equitable distribution and redistribution of resources and power, which Director Allen also pointed to earlier today. And very importantly, recognizing, reconciling, and rectifying both the historical and contemporary social and racial injustices that continue to plague our systems and the peoples that are working to interact and working to be helped by the system. And we have found that in this day and age, 530 years of colonization and inequities persist. And so we are here in this very monumental time to change that course, to achieve our goal of eliminating all inequity, health inequities in the state by 2030. Next slide, please. So today we have a twofold approach to our presentation. We are really fortunate to have the opportunity to present to you proposed new members for the Health Equity Committee, and that is indeed for your approval. So we appreciate the opportunity to present this information. And then we'd also like to provide progress on the Health Equity Committee Charter and an update on that work, and that is for your information. And to back up to context, because context is just as important as content, especially when working with health equity, the barriers to health equity, and honoring the experience of people in this work. So as you have already noted, we are in a time of great transition, not only in our agency, but in our state. And that's not different with the Health Equity Committee at this point in time. So we have a variety of members who are terming off at this point in time, and we're adding new members. We also have a newly approved 1115 waiver and CCO 3.0 on the horizon, and leadership transitions in the state and in the agency. So it seems that everywhere we turn, transition is happening, and it is a natural state of who we are as humanity and as societies. Without change, we wouldn't be living in many respects. So we really want to explore this question as well as we proceed today, and that is how can we sustain the advances in Oregon that we have all made together in advancing health equity? How can we continue this work to eliminate health inequities by 2030. And given these upcoming transitions, which I am confident that the leadership around this Zoom room, if you will, and the work that's being done by the agency and throughout the state, the work that's being done by communities, that we will continue this work full ahead on this. In this conversation, it's also, I think, important to consider that the goal to end inequities has always been implicit in the mission as a state and as an agency when it comes to health systems transformation. What has changed, you might say, is that in 2018, that became very explicit because our director, Pat Allen, stated publicly that we are not going to be able to fulfill our mission as a health systems transformation, as an agency, as a state, and that mission being optimal health for all people. We will not fulfill that without addressing and eliminating the inequities that are preventing people from having optimal health, that are creating those health gaps. So this is something that has been a part of the legacy of this work, and not just in the last 10 years that this agency has been in existence, 10 plus years now, I guess. But really dating back, we always say centuries, because this the legacy of wisdom of peoples has always prevailed, even in the, when faced by enslavement and genocide and a variety of other atrocities. People have prevailed. And this work actually began in the state, in the public health system back in 1992. So we always acknowledge the long-standing, decades and centuries old work that has been done. So we really have to continue that trajectory, and we need to do it consistently, and we need to do it intentionally, so that health equity is embedded in the foundation and it is a framework for health systems transformation. And so this is not new, but what is new is the attention, the leadership, and the fact that government is looking to change to be of greater service to the people of this state and of this nation. Next slide, please. So we're going to go into the recruitment now, and I'll present that information to you. I'll talk about the process as well as present the slate. Next slide, please. Okay, so this is the circumstance. We, as a Health Equity Committee, have needed to recruit for 6 positions. We had 2 vacant slots and 4 members that are ending their service in December 2022. I want to acknowledge the work of not only the Health Equity Committee and the sub-team that worked on this recruitment, but also our team members in the Equity and Inclusion Division, Maria Castro and Alex Friedman and Shelley Doss, and many others that helped to support the process. We have a great team of people. And that was, I think, really apparent in the fact that this work has taken an approach of looking at the gaps that exist in the current composition and the gaps that exist in the upcoming with the upcoming changes and vacancies. So a gap analysis was done, and that identified priority populations to that where we focused our recruitment throughout the state. And I really want to say throughout the state, that is critical. And so we are also worked to recognize the race, ethnicity, language, disability, sexual orientation, gender identity, and those demographics, which were kept confidential, of course, and anonymous, of course, and also geographic representation and intersectionality as well. So all this entire framework was served as a foundation for moving forward. The recruitment opened in September and closed in mid-October. And we had an extensive process to seek applications through the Health Equity Committee, through this policy board, through the Community Partner Outreach Program, providers, academic networks, and community-based organizations, and really leverage the relationships that we have with previous applicants and with Oregon Health Policy Board committees to tap into interests that might exist there as well. And then we did indeed do an extensive scoring, piloting an intersectional scoring rubric model. And that integrated lived experience, identity alignment with the priority areas that came through via that intersectional gap analysis. And Health Equity Committee members, which I pointed to, and our equity inclusion team participated to score, to read and score those applications. So once again, it's never a one-person effort, it's many of us. So let's see, next slide, please. So this shows some of the recruitment highlights around the focus on intersectionality and putting that into practice. This helped to give us a greater depth of representation, and we did identify some priority identities, people from the trans community, the Latino, Latina, Latinx community, people who have immigrated and sought refuge here, and a variety of other priority populations that relate very specifically to the populations that are most harmed by inequities. So we're working to bring in new areas of representation as well, which is very exciting, students and youth, and regarding equity skills and expertise from multiple perspectives and multiple points of view. And I think the success of this recruitment is really that there are people out there that are doing this work. And I do recall one point in time when there was a question posed in another arena, well, is there anyone even out there? How do you recruit? Well, we have had such an incredible ongoing outpouring of interest that the message is, yes, there are people out there with the expertise and the interest in serving, and we just have to do our job on our end to make sure that these opportunities are made known and that we are cultivating relationships, because it's not simply enough to send out an email and say, hey, y'all come, let's all apply for this. It's really about cultivating and maintaining relationships that get us to that true point of engagement. Next slide, please. So here I'm presenting to you the Health Equity Committee new member slate. And this is information that should also be in your packets. So all these individuals are highly, we recommend all these individuals for this work. This was a highly vetted process. There were more people than we could include in this slate that would have made ideal members. And when all was said and done, these are the individuals that we are proposing to you to be the newest members of our Health Equity Committee.
Thank you so much, Leanne.
And then we also have, pardon me, renewing members are next. I'll just get through this very quickly. And then the next slide. And these are the members that we honor that are ending their service as well. So I will leave it at that and say thank you, and pardon me for my interruption, Chair Rana. Did you have a question? And if not, I'll send it over to I'll send it back to you and for any conversation about this slate. Thank you.
Oh, no, thank you so much. I just wanted to make sure, is this the, I know it's a two-parter presentation. Do you want us to take the vote at this point and then move on to the second part of the presentation, or sort of to discuss the slate and take the vote?
Well, the slate is fresh, perhaps questions, comments now, and if you would like to take the vote, we would certainly be welcome to accept that. Thank you.
Yeah, let's do that right now. If Madeline, if you could go back one slide, maybe, just to make sure that we have it on our minds. One back a slide. There we go. And then maybe one more. Right. Thank you. Well, so I just want to say thank you, Director Johnson and your team and the entire Health Equity Committee for all your wonderful work getting to this point. I also just add that we heard from the co-chairs of the Health Equity Committee before our meeting today, a couple of times actually since our November meeting, and we got to get updates. Both Kirsten and I heard updates on just the slate and all the work that they were doing. They recently had the Health Equity Committee recently also had a retreat. So it's been really wonderful to see all the progress that they've been working on. I wanted to see, not to put you on the spot, Sandy, if you're in a good spot, just as a liaison, as a board's liaison to the Health Equity Committee, I was wondering if you had any comments to offer.
No, I had reviewed a lot of the information that has been presented and fully recommend moving forward.
Thank you so much, Sandy. We'll go ahead and take that as a motion to approve the current slate. Can I get a second, please?
I can second.
Thank you so much, Melina. All right, all those in, oh, Brenda, looks like you have a question.
Yeah, I do. Thank you so much. And I support this slate, so this comment is mostly around recognizing the geographic diversity. I think in the supplemental materials, it illustrated that we are a little Portland Metro centric, at least in the committee composition at this point. And I'm certain the committee has done its due diligence in thinking about outreach to rural parts of the state. So I again support the notion. I just wanted to call attention to the importance of that as we move forward with future recruitment. Thank you.
Thank you so much, John.
Yeah, I support the slate also, but would just ask that older Oregonians also be remembered. It's people over 65 who are really dependent on the healthcare system. And I'm not sure how many people over 65 there are on the committee, but just remember those folks. Thanks.
Thank you so much. Any other comments or discussion before we take the vote? Looks like Ebony. Oh, Ebony, we cannot hear you for some reason.
Can you hear me now?
Yes.
Okay, I was gonna say ditto to what John said. And I just truly do appreciate that continuous lens around, always reflecting on what additional voices, perspective needs to be considered and brought to the table. And so that continues to be reassuring for me. And so thank you for all of the intentionality that went into this.
Great. Any other thoughts or comments? All right. And well, I'll just continue to say that I really feel like the Health Equity Committee continues to sort of, be the model or set the example for all other OHPB committees and all other public committees out there in terms of recruitment, intentionality around recruitment, intentionality around retention and involvement. So thank you so much. So we heard the motion from Sandy. We got a second from Melina. All those in favor to approve the Health Equity Committee's slate, please say aye.
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 Anybody opposed? All right, anyone abstain? All right, that is unanimous. Thank you so much. Again, congratulations, Director Johnson and your team and the Health Equity Committee as well.
And the state, and we congratulate the state of Oregon as well for being here and for stepping up. Thank you. Appreciate it. Thank you to all of you. Appreciate the vote.
Yes, thank you so much for all your leadership and all your work. And
I will.
And do you want to transition it over to Jorge and Stick?
I sure do. Thank you so much. It's my pleasure to introduce Jorge Ramirez Garcia and Stick Crosby, who are currently serving as our co-chairs for the Health Equity Committee. And certainly each can say more about who they are, and I will pass this over to the two of them. Thank you so much. And I think we have some continuing slides as well.
So if we could go to the next slide. So I'm Stick Crosby, my pronouns are he, him, and his, and Jorge is here. We're gonna tag team these slides, and I think the plan was then Jorge would introduce himself on slide 16. So we'll just kind of go through these. We wanted to give you an update on the process for our charter with the mission, vision, and values. I did want to open this though, and thank you, Chair Ron and the committee for giving us this space to talk about this. And I want to go back to your comments, Chair Ron, about the consistency and historical knowledge. This came at a great time in this process to make sure that we were capturing that with some founding members of the committee still there, and some OHA staff that were really critical in all of this work over the last several years. We had a lot of goals within here, and part of this was accessibility. We wanted to make sure that we were leaving with something that future advocates and individuals that were coming to the committee with issues and giving input would have tools to point back to our mission, vision, and values for giving comment, and then also possibly comment here to the main board. We wanted to be action oriented. I do think the health equity definition is very action oriented. That said, sometimes equity can be passive. If we look at the class standards, even though they were built upon many different things, they can still be very passive in the way that they're implemented and required throughout the system. And that involves embedding more equity throughout the process, right? And really anchoring it there so it is a priority through these transitions that are coming up as we go through this. This process was driven with the HEC members. It was really important that they were included. We met weekly. Every Monday, I turned into Garfield. I hated Mondays, but we continued to work on this. And then a real critical individual as part of this facilitation was Michael Anderson Nathy. He was one of the original members. He was I believe the original chair of the committee. And Michael really guided us, and I cannot express how grateful I am for the opportunity to have been able to work with him again. And he also helped facilitate our retreat, which just, I'm going to talk about in a minute here, was really great. We were very expansive in our approach. So you've got the traditional pieces of the charter, but we've really expanded that with our mission, vision, values, which you're going to see in Jorge's presentation here. So much engagement involved with this, and then these critical conversations. We did take our time, and we did adhere to that rule when you're doing this work, and not to rush through just to get it done. And I think, Chair Rana, we originally had a timeline of approving something in November, right? And yet we're here in December, but that's because we had to get to this place that it was something that we wanted to give to you that made sense, that was actionable, and had equity embedded there, and was this anchor for moving forward. We go to the next slide. So we had our day-long retreat, November 1st. I don't know how well of a job we did documenting that format, but I have never been through a hybrid event that I really was lost in it. I unfortunately was not able to travel that day from weather and other issues. And was one of the hybrid individuals, but I felt I was in the room, and I was really impressed. And I hope the OHPB can learn more about that from Maria and Michael and Leanne to make sure that anytime you do these types of events, it could be more inclusive in work. And going back to Brenda's point about different folks across the state and participation, it was really well done. I can't express that. The culture box activity was a major highlight too. You know, I'm a white, straight, cisgender male, right? So it's easy for me to forget about culture, and that culture is hamburgers and hot dogs, right? And it was just a really good activity to express who we are, where we're coming from, and the different perspectives that we had there. So I always appreciate those opportunities, but Michael is an amazing facilitator, and that understanding was not on the backs of others in the room, right? Really using your own experience to have that. And that's something I look to as a facilitator myself, and I was really impressed with. We were able to hear from Director Allen and Chair Rana there. And I want to highlight this most importantly. Director Allen has been very engaged with our committee, and I hope that continues with this transition. And I hope you all make sure that that accountability is there for that to occur. And I think with the chair that you have now, that will happen. But it's really important that that engagement occurs and that those discussions happen. And nothing bad to say. I do think it's important though in the future, if somebody does try to change direction, that there is accountability and at least they have to speak in person about why they're making those changes that may go against this 10-year goal that we have here. And then we focus the rest of our time on drafting our health equity mission, vision, and values statement, which will go to our next slide. And really, these were the key discussions that we had within there and that we were trying to frame, and what came to what I'm going to hand off to Jorge in a minute here for his slides. And that's what is our role in policy development? Are we actually creating it? Does this 14-member committee actually have the bandwidth to create this policy? Or are we using our lenses to guide that and to hold the OHPB accountable, right? Which direction does that go? What are our priorities going to be over the next 2 to 3 years, especially in this time of transition and uncertainty? When it comes to the OHA and accountability for advancing health equity and anti-racism, that's critical. That's very critical. And this can go backwards very fast from the work that the director had highlighted earlier. What does developing an anti-racism racist commitment statement for OHPB and OHA look like, and how could it advance our efforts? And then what is our mission, vision, and values when it comes to advancing health equity? And that's what we focused on the charter there. I apologize in my opening statements. I had highlighted a lot of folks, but I did want to highlight Jeff Scroggin. Also, I know he's not on the call anymore. Jeff met with me on the last Thanksgiving with implementation of HB 2359, which was the interpreter legislation, and was really pushing hard and was an internal advocate for that work when it came to language access. And we're nowhere where we need to be. I think the folks that presented earlier on the one system did a great job, but we were hearing about interpreters, right? Really, what about the bilingual folks that are then doing direct service, right? That's real customer service, which I think they're working towards. But I really want to highlight that, because in this time of transition, there's these people that aren't as highlighted as much as their director that are doing that critical work on the back end to make sure this happens in those key connections. So I wanted to make sure to say that. And with that, I'm going to turn it over to another great advocate that's in the background and here as my co-chair, and that's Jorge. And I'll leave his introduction to him.
Good morning, Chair Arana, members of the board. Thank you very much for the opportunity to continue to advance health equity and engage with this committee. And I also want to take the opportunity to join everyone and thank Director Allen for his concrete and impactful support for health equity. We've come a long way, and our umbrella question is how can we sustain that? We'll get back to that. I'm here to present the mission, vision, and values, a current draft that has been vetted by our committee and developed in a very participatory, engaged fashion. This is part of our ongoing strategic plan to advance health equity through defining the scope of our work and being very clear and intentional about our definitions and the organizational aspects of a charter. But we want to present this draft mission, vision, and values because of its importance in terms of interfacing that charter with a public-facing mission, vision, value statements for our state. The current version reads as follows: HEC works to eliminate health inequities for all people in Oregon, especially those most harmed by racism, colonization, and other forms of current and historical systemic oppression, injustice, and discrimination. We achieve this through advocating for the adoption and implementation of best practices to advance health equity in Oregon and monitor its progress. We collaborate with OHA and OHPB committees to support their efforts in advancing health equity and social justice. And we support health equity policy development informed by communities that have been economically and socially marginalized. You will note that this mission statement aligns very closely with health equity definition, and that it focuses in the drivers of health and health inequity. And of course, the hard work of being here present in the collective effort to collaborate with OHPB and OHA wide. Our current HEC vision statement reads as follows: health equity is a fundamental right. All people in Oregon are safe, supported by community, and have the freedom of self-determination and can reach their full potential. And well-being. This health vision statement, as you can see, highlights our responsiveness to the whole state and also emphasizes the contemporary definitions of health. It's not just the absence of illness, it is achieving people's health potential. Next slide, please. Our values, our current values, again, racial and social justice, spell out specific components of structural determinants of health and of health inequities, such as reconciling and recognizing historical and contemporary injustices. Our second value is, of course, diversity, equity, and inclusion, which is fundamental for all efforts in equity in health and across all sectors, as we know. We can only achieve that through diverse teams and work and inclusive environments. Next slide, please. Our next values are partnership and advocacy, highlighting the importance of cross-sector collaboration, stakeholder community involvement, and engagement and participation and co-creation. It takes a village, right? So partnership and advocacy are part of our proposed values. Again, health equity for all in Oregon, our intent being intentional to be responsive to all people in Oregon through all the corners of the state. And last but not least, the value of really recognizing the hardships, but also the culture, the contributions, ever-growing contributions to society, and sovereignty of Native and tribal communities is our value here. So next slide, please. So at this point, in terms of that is the draft, and we want to engage and update you into our next steps, which include incorporating OHP feedback to finalize this mission, vision, and values that are presented as draft. They're not ready for finalization and voting. But this is an important part of the process to obtain your feedback. We are, of course, steadily working on updating the HEC charter and statement of work, and we will be bringing that obviously back to the board. We are identifying strategic priorities for the next year, and obviously long-term ones, but it's critical to start with the short-term priorities. And as we just presented you, the onboarding of new HEC members that we will be working with. Next slide, please. So we want to provide the space for two big questions, or two sets of questions. One of them is basically your initial reactions on this draft mission, vision, and values. But of course, in addition to receiving important critical feedback on this set of mission, vision, and values, we want to ask ourselves collectively with you, how can we sustain the advances Oregon has made in health equity and continue to work to eliminate health inequities by 2030. It's the bigger umbrella questions. So we will open up the floor now for the first set of questions. If you have any reactions for the mission, vision, and values. Thank you.
Thank you so much, Jorge and Stick, for your presentation. Comments or thoughts from fellow board members about these questions and their presentation? Brenda.
I am really quite grateful for the level of work, attention, and detail that has gone into this that we're reviewing today. I also really appreciate the TO2, the context that you've all set for us as we consider the amount of time and energy and effort you've put into it. So that's very, very helpful. I have no edits, to offer to the group. I think directionally it feels in alignment with many, many conversations we've had as a board and in our committee structures. My one question for you, and it may be premature, so happy to have you come back and reflect on this more, is really around the behaviors that are tied to these values and these principles. So how will we know we're living into this aspirational set of expectations we're holding for ourselves? So again, that's something perhaps as you review them, you'll know and be able to determine our success in doing so. Thank you.
Thank you, Brenda. Other comments from board members? John.
Yeah, two things. One, I thought it was really interesting to see that you now have an equity scientist on the committee. And, science is a specific way of thinking about things and sorting things out. And for myself, I'd be very interested in how science is applied and helpful in this work, and interested in reading, anything about how you go about doing that. So I just thought that was very interesting, that the committee was going to have that resource. I also have no specific comments on the language that you've provided. It's ambitious, as I think the priority that OHA has set is ambitious. I do have one source that you might find of value in the future. The Task Force for Universal Health Care commissioned an independent actuarial study of how a single payer would compare to the current multi-payer system that we have. That study, while it has its limitations, provides an opportunity to have a sense of how much inequity we're funding in the current system, and provides some provocative ways in which power and resources could be transferred. The one that I like the most is currently commercial insurance is paying twice the rate for healthcare that Medicaid is. Is it any surprise that the system, when it looks at where it's going to build, where it's going to expand, what it's going to do in the future, tends to favor communities of folks who are white and wealthy? That could be changed. It would be a almost $9 billion transfer of resources. That could be changed. So there's several other health equity strategies identified, and if you will, a resource estimated around those, and at some point, the committee might think about looking at that. Thanks.
Thank you, John. Ebony.
Okay, sorry, I'm using my phone for audio. One technical issue. I assume that when the mission, vision, and values are finalized and approved, that HEC will at least be initially spelled out at the top somewhere, is my assumption, because it's just a draft. So my real question is, just want to highlight and appreciate the call out for leading with race, and just wanted to know where can folks find the definition or statement specific or that kind of surmises or defines what y'all mean by leading with race.
Do you want to take that, Jorge, or you want me to?
Well, I will say briefly that the health equity definition implicitly calls out that Oregonians and individuals in Oregon will achieve health equity and will not be disadvantaged by, and then it spells out race, ethnicity, language, age, disabilities, and so forth. So that's one implicit, but perhaps our board members asking for more explicit statement about leading with race. Go ahead,
And,
Stick.
and actually, can I preface what I mean by that? So in Multnomah County, we have a firm value of leading with race, and what we had to do was, that was one of the questions that we will always get. And so we actually found the need to actually have that kind of documented somewhere specifically. And obviously there's those clear intersectionalities and through lines to kind of the broader, mission, vision, and commitments and values. But I'll just say, our learning was that we found it very helpful and found that oftentimes folks were also asking for something in writing specifically, kind of noting what we meant by leading with race. So that was where my comment was coming from, to just share kind of lessons learned.
Yeah,
Thank you.
Yeah, so there's more to this document to be shared too, that we are also forming a definitions section. We're going to define anti-racism. There's a whole component of this that I think would be added to that, Ebony. Specifically this language, I think this is is part of the discussion. I had really pushed for the concepts that Race Forward puts forward. That's the nonprofit organization that they do a lot of policy and advocacy in this space, and that I've used in the past, and I think OEI uses, and that's the specific, if you were to ask me right now, what definition am I using? I would use the one there that they use. But it is becoming its own. The work group is forming definitions to these. And I think it's really important to remember that this is, I really like how Director Allen had highlighted this in the beginning, and that we were pulling this up to make sure that it wasn't only that the COVID vaccinations were not only occurring within certain group, that we could mask certain inequities within there. And I think that's the goal, right? And one of the things we're trying to push and really get OHPB to hopefully adopt in everything that you all review is that yes, we may have a good metric here, but what else is underneath that metric, and what are we getting to? And starting with race, but then getting to that intersectionality from there, I think is really important. To go back to what Dr. Santa mentioned on this task force for universal healthcare, where are we leading with it? Where are we looking at those with possibly communities that are doing financially well? And then if we went to universal healthcare, if the issues in the system now for communities of color would then cause a backstep in their healthcare with what's there. So there's all kinds of these different areas to look at within the system and understand where we are. But I hope I answered your question, because I feel myself starting to ramble, and I don't want to ramble with your all's time. So
Thank you, Stick. Couple of thoughts from my end really quickly. I really liked what your process. I really like all the language. Kind of had a question regarding the tribal sovereignty value. It talks about the 5 essential components of health equity for American Indians and Alaska Natives. And based on what I just heard from Stick, there's like a definition section coming up. So maybe in that definition section, those 5 essential components will be included. Because I think for me, I had that question. It was like, oh, that's really interesting. What are those 5 essential components? So that's pretty minor. I really, like that part of the mission definition is about collaboration and encouraging collaboration between the Health Equity Committee and other OHPB committees. We've had a lot of conversations, throughout this year, particularly that were showing up on our retreat, that there's a lot of committees, right? And not enough board members, and we don't have enough board liaisons. And sometimes, like the committees the committees are a priority of the board, yet we don't have enough like board members or capacity to be fully attentive and present to all of the committees. So I really feel that the Health Equity Committee could play a really critical role in helping with that alignment of all the committees. I feel like your work around this charter could be a really excellent example for all the other committees to potentially take a similar approach in terms of updating its priorities, its practices, its values. So yeah, and obviously we're always short on time. I really appreciate some of these really big questions. I would just say I would encourage my fellow board members to be thinking about them as well. And, as we move forward, always feel free to like email me or Kristen your thoughts around these on how to answer these questions. And we can make sure that we get that information back to the Health Equity Committee leaders. I want to make sure any other comments or thoughts on this. Melina.
Hi, just really quick. Thank you for that presentation and all your work you're doing. I think it's just going to, give more power to health equity in Oregon, give more power to workforce diversification, cultural appropriate healthcare, and give voices to the prioritized communities. I'm looking forward to your goals and priorities. And I think you said you had one priority of an anti-racist policy. Was that what you had on there? I don't have the slides. If it is, I think that I feel like we're behind the times if there's not an anti-racist policy already, and that needs to be elevated along with everything else that you're working on. And thank you.
yeah, so that's an anti-racist commitment statement is what we're working on, and then that could definitely be drawn for policy and decision making from there. To go back, I do want to highlight, since I won't be here, I want to also go back to what Brenda had mentioned, and how are you living these values and things like that. We're really hoping that we're trying to build the structure, but all the individuals within there are too. So in the future, if as that statement is created, you have to constantly draw back to it. These documents can't be static. And you can do that to then create that policy and systems change down. I mean, because you all are it, right? You're the top in the hierarchy to drive that down and through the system. And with everything you're doing and hopefully pushing to your other committees that they are doing that and that they are going to commit to this, I think is important. And that exactly, I agree with you, and I hope I answered your question.
Any final thoughts or comments from the board? Well, thank you again, Director Johnson and Stick and Jorge for your presentation and all the work that the committee members do and that your team does as well, Director Johnson. So I'm going to transition it over. Go ahead, Leanne.
Oh, I just said thank you. Thank you. Appreciate you very much. Thank you.
All right. I am going to move on to the next agenda item. So it looks like Dave Inbody is here to talk a little bit more about CCO 2025 procurement process. So go ahead, Dave.
Hey, thank you. I appreciate it. Yeah, and I'm Dave Inbody. I'm the CCO Operations Director for OHA. I think I have some slides that can be shared here. Yeah, there we go. You can go to the next slide, please. Just what was basically what I'm going to cover for you today. Go through a really brief history, and then some of the changes that have happened since the last procurement process. Talk a little bit about CCO 2025, the CCO performance under the current contract, focus on policy and requirement review, a little bit about the project structure and the associated timeline. Go to the next slide, please. So going back to the beginning, starting with House Bill 3650 in 2011, where CCOs were established. And the reason why I put this in here is to talk about, when that originally happened, what were the basis for that, and what was kind of some of those guiding principles, and ensuring that we have that as a thread that runs through the process. So as we look to go through the next procurement process, ensuring that those are there as well. Integration and coordination of benefits and services, local accountability for health and resource allocation, standards for safe and effective care, global Medicaid budget tied to sustainable rates of growth. And when you look at that, you can see that so many of those things are a part of what we're doing in those contractual relationships with CCOs. And the overarching concept that was shared often at that time was, rather than spending, cutting back as a way to cut costs associated with an inefficient system, let's look at the system and change it, make it better so that it's more efficient, and that it truly has value, and that we see better health outcomes. So, next slide, please. As we step forward to the second contractual period, at the time, Governor Brown had provided 4 key areas of consideration that are reminiscent of what was shared at the beginning, but I think expanded a bit. We look at the focusing on social determinants of health and health equity, increasing value-based payments and pay for performance, improving the behavioral health system, and then maintaining sustainable cost growth. And as part of that, direction was provided to this group to provide some recommendations. And we've gone through that a little bit at last month's meeting in terms of the 43 policy recommendations, but that's really provided some clear guidance in terms of what are the priorities and what are we wanting to focus on during CCO 2.0. And as a result of that, part of the contract included over 200 different CCO contractual requirements that speak to many of these considerations and recommendations. Next slide, please. So in looking at where we've gone since the last procurement process in preparation for the next one, one is to look at so many of those significant programs and policy changes. The first is what I'm calling digesting all of the CCO 2.0 requirements. As I mentioned, there were over 200 requirements that were placed on CCOs. And part of that digesting is not just understanding what we're trying to achieve with it, but also determining if the requirements that we put in place, are they the right ones? Are they getting us to the intended goals? And are there things that need to be changed? And references have been made to the fact that there's a lot of administrative requirements. And the question is, are those administrative requirements the best way to indicate whether the CCOs are performing as expected through contractual requirements? So part of this is refining and improving the oversight of that work, but also assessing whether it's actually the right approach to begin with. The second piece is the incorporation of the 1115 waiver. As we move towards implementation of the waiver components, that's going to be a key part of what is new and different in this new procurement process, this new contract. Another is the significant number of behavioral health legislative initiatives that came out, especially in the 2021 legislative session, many of which, as the dollars are reaching their intended sources, their intended ends, are we starting to see the impacts that we wanted through that process? And taking that into account when we think about what is it that we're looking for CCOs to do in relation to behavioral health, and what is that relationship? And then the last is just the changes in state government leadership. Look at not just a new governor, but a significant number of new members in the legislature that could have a potential impact on what are set as priorities and where we're looking to in the future. The other is obviously the public health emergency, and a couple of things that particularly may affect the contractual components of this is service delivery changes. You know, what did we put in place because of the public health emergency, and which of those things are worthwhile to maintain regardless of whether it's a public health emergency or not, and which things go away. And that process is part of what we're going through now. The other is, as we prepare for the end of the public health emergency, the reality that there is a significant number of people that are currently covered under Medicaid that will no longer qualify for that as the end of the public health emergency arrives, and how best to address that. And I think the presentation after mine will give you one of the solutions, but I think as it relates to the CCO contract, we have to take into account what were the impacts of that. And then the other is just the maturing the CCO model. You know, when you look at where we've gone through, that first contract was more or less saying, is this something we can even do? Does this model make sense? Does it work? And then the second one, as we added so many of those policy considerations, it was, you know, what is it that we want this to be? And how do are the CCOs performing in the way that we had anticipated they would? And if not, what changes do we need to make? I think now it's time to think about where we want to go to in the future. And some of these things to take into account is identifying the realities that there are variances between CCOs, whether it be geographic, whether it be the size of membership, their organizational structure, that have impacts on how service is delivered. And what does that mean contractually? Right now, we have the same contract for all CCOs, and that means that there is some standardization that happens here in terms of our expectations. And depending on what CCO we're talking about, in what area and their size and their organizational type, that could have very different impacts on ultimately on the members and how they receive service. And this speaks to the broader consideration of that weighing that distinction between standardization of services and allowing for that local flexibility. What needs to be something that is a standard that's set, a minimum requirement, or a shared or equal or equitable approach to particular service delivery, and where are we looking to allow for CCOs to be a little more flexible and provide a little more creativity in terms of how they approach and reach those ultimate outcomes. The other is the evolution of what we're now calling the non-Medicaid contract. We used to refer to it as Cover All Kids contract, but with the onset of Healthier Oregon and now the addition of Veterans Dental Services beginning in January, we now have a contract that is kind of they signed the Medicaid contract, and then the CCOs also signed the non-Medicaid contract, but we've never really looked at that contract as something where there may be unique and different requirements or needs for the members that are served by that contract. And so that is an area where there's probably more opportunity to do that this time around. And the reality that is an area that will likely grow as eligibility for services outside of Medicaid that we're still looking to CCOs to provide will speak to what changes we might want to make there. And I think that also speaks to the basic health plan as well. And next slide, please. And this is some of the considerations, and I say kind of tongue-in-cheek that it's CCO 2025, not CCO 3.0. And the reason that we say that is part of the hope is that this next step isn't starting anew, it isn't starting over. It's really taking on what we were doing in 2.0, figuring out what was working and supporting that and moving forward. And the places where we struggled, how can we do this differently? How can we improve it? And where do we need to reevaluate and maybe move in a different direction? And so we've been referring to it as CCO 2025 with the idea that this is a moderate step as opposed to a huge, big, dramatic change. But some of the things that are key, that we believe are key to this change, and these are some considerations to take into account, is that starting from a point of thinking about that 2030 health equity goal, recognizing that this contract would expire, the end of the contract would be in 2029. So if we're going to do it, we really need to do it within this contract period. The next is building on the priorities and the structure, or building on existing priorities and the structure we have now, taking into account those policy recommendations that were provided and how we performed against them, where we need to make changes. And the other is taking into account, do we want to say that we're only going to offer this to existing CCOs as an option? This is one way to limit the approach where you're not bringing in new participants into the process. That's one way that can potentially be narrowed. Proceeding without delaying the procurement process. And one of the things, and the reason for that is something that requires legislative activity to change what's currently required. Right now, we're required to offer a 5-year contract and go through a procurement process to get there. So any changes to that process would require legislative action. Now that's possible, and if we do want to go in that way, we can do that. But in order to do that, we'd have to take additional steps. Leveraging our current CCO performance as a basis for evaluation. One thing that we haven't necessarily had to this degree in the past is we have a track record for the CCOs that are performing now. We can use that as a basis to figure out what changes need to be made in the upcoming contract. Obviously, elevating the role of the members, the community, and the external partners in a collaborative decision-making process and moving forward on this contract. And this speaks to, I think, many of the things that have been shared in the previous presentation, is that idea of how do you evolve from a place where you're asking questions and then bringing that information back and then making decisions with it, to a more collaborative way of coming to a decision-making process, recognizing that all of those component participants are impacted by the decisions that you make. And then the unknown at this point is, will there be significant priorities and expectations from the governor and the new legislature in relation to this contract? Next slide, please. And I went through some of this last month as it relates to the policy recommendations that the Oregon Health Board had provided. But just as a reminder, of those recommendations, those 43 recommendations, 83% of them were either met or partially met, and 58% of them, the intended impacts were achieved or partially achieved. What I highlighted here are some of those areas where it seemed pretty clear that what was originally anticipated or the expectations that were set, the progress had been made in the way that was intended, or appeared to be made in the way that were intended. As it relates to social determinants of health, value-based payments and pay for performance, health information technology, sustainable cost growth, and compliance monitoring. So the idea is take what was done there and see, what is the next step, and what progress do we want to take for those things, recognizing what we've done in the past has moved in the direction we were looking for. And then those areas where we didn't fully achieve the impacts that we were seeking, whether it be health equity or traditional health workers or healthcare integration or behavioral health workforce or behavioral health, the children's system of care or residential services or pharmacy and PBM oversight. Do we continue in the direction? Is it just that we didn't achieve what we wanted to, or is it a place where we reassess and determine, is there another way to get there? Can we get to these intended impacts in a different way? And next slide, please. The other part, and this is kind of what I referenced about using the oversight that we currently have and using existing deliverables and existing requirements as a basis for moving forward. These are areas where there has been either a lot of attention, a lot of energy, or there have been challenges, and probably places that we want to spend a little more time as we look to the next contract. Things like language access services, fraud, waste, and abuse oversight, grievances and appeals, NEMT, network adequacy, care coordination, all these areas we've done work or are doing work, either have work groups or there's other work that's being done in those areas, the places where there's definitely an opportunity to make improvements as it relates to that relationship with CCOs. And then there's the broader structural considerations, things like financial viability expectations or subcontracting oversight or organizational structure or the current expectations for community advisory councils. Next slide, please. So the most immediate requirement that we have is in submitting that there was a budget note in our 2021 budget from the legislature that is asking that we come back before the end of this year and provide a report that kind of outlines our expectations for this next procurement process, including the anticipated milestones and deadline dates, outlining how the process will provide public transparency and communication, and then anticipating the resources that the agency will need to perform this next round. And that's due at the end of the year. Next slide, please. So some of those considerations, this is a broad timeline. And obviously this is based on where we stand today, and things can change. But the expectation is that we're thinking about it in terms of these four phases, starting with the initiation phase, the phase that we're in now, where we're looking at defining the objectives, reviewing the CCO's performance up to this point, identifying the resource needs, and then obviously completing the report. And then moving into the planning phase, where we develop a full, thorough project plan, start community engagement, complete a full risk assessment, and then establish a technical advisory committee for ongoing engagement. Then moving into that execution phase, where we release the RFP or RFA, then receiving submission and evaluation of those that are returned, contracting, member transition, communication and education throughout that process. And then finally, the implementation and the closeout. This is establishing accountability requirements, continued communication and education. The new contract becomes effective January 1st, 2025. And then afterwards, conducting lessons learned on that process and then creating a closeout report. Next slide. And this is how we're approaching this project structure, kind of in four parts. The project plan itself, which is how do we go about walking through these steps and what does it look like? The implementation and outreach plan, and engaging people beyond just OHA in this process and what that might look like and how we're going to interpret feedback and engagement and as I said, that collaborative decision-making process. And then the communication plan, and this communication plan, both internally to CCOs, to the community, broader consideration and the timing for that. And then ultimately an implementation plan. How do we carry this out? And what pieces, what key action steps need to be taken to do that? Next slide, please. And then you can see how some of these would feed into what we are putting together for the legislative report, but recognizing where the engagement and outreach plan, being one key step, recognizing that part of this is just as I said, finding a way to not only just listen to what's being said, but also to integrate that into the work that we're doing and make it a part of the decision-making, ultimately the development of that contract. And some of the places where we're looking at doing that is there's the direct community engagement. There's also the education and information shared, and then finding places where we can empower and provide accountability to those that we're dealing with. You know, one of the things that we've heard often is that we may do pretty well at asking the questions, but we don't always do a great job of coming back with the answers or following up in a way that there's actually engagement. So it's more instead of talking to or hearing from, but actually engaging each other in that process. And I think that's one of the, setting those high marks to try and get there. And one of the ways that we'd like to do that, and looking for the Health Policy Board's assistance here, is actually leveraging some of the work and some of the progress that's been made in these areas with some of your committees. as was just shared in the previous presentation, all the work that's being done by the Health Equity Committee in trying to expand and actually approach the work that we do in a different way. I think the same thing needs to apply in this type of project as well, is how do we do this in a way that actually incorporates that work and is able to leverage that work to improve that process. Next slide, please. So the other piece, the communication plan, and this is more about how best to target this, and it's broad strokes at this point, but I think once we get to a place where we start seeing content and process more specifically, this will become more key in how we approach it. Obviously, you can see that there's a variety of different audiences that we'd be wanting to reach out to try and ensure that they're included in this process. Next slide, please. I think that's it. All right, I know that was a lot of information, but I did want to get that out to you and share with you, but I am interested to hear your comments and questions.
Thank you so much, Dave. I really appreciate all the information that you packed in your presentation and going through it pretty quickly. Questions and comments from the board? Brenda.
Thank you, Dave. It is a great body of work. I have two questions for you. One is probably more of a dissenting opinion around the name change. I know as we created CCO 2.0 that almost immediately after the contracts were signed in ink, the conversations about what would CCO 3.0 was a vernacular that was used and is currently used in communities. And while I appreciate the framing you gave around the intention between this isn't an overall wild transformation of the model itself. It is iterative in its improvement notions. I'd like us to really consider what communities are used to using and what they want to call this transformation, this next stage, as opposed to just kind of imposing that shift. Largely, I think it'll become something that will be used anyway. So again, I appreciate the intention around it and just a bit of pushback on that design. My question actually is really specifically around the role that we're envisioning OHPB will play. I see us modeled as an audience, and I'm curious if you can give a little bit more detail. You did in the inclusion of committees as part of the planning process. I'm curious about the board itself.
Yeah, and I think that's still an open question, but I do recognize, and I think there was incredible value, not just at the time of the procurement, but throughout the implementation of CCO 2.0 in having those guiding recommendations that I think are some of the things that are key to this process, is hearing and getting some indication of where you see us going. I mean, you've been directly involved in the work that's been done over the last 5+ years, and what is the next step? Where do we need to take that? And so I see it more than just an audience, as you mentioned. But the other is, as I mentioned during the presentation, there's a lot of valuable work being done through your committees that I think are key to some of the work that needs to be done for this process as well. One of the things that we've been trying to work on internally is how can we leverage the work that's being done in other groups that affect this work. For example, you look at all the work that's being done around the waiver implementation. Our hope is that we won't need to set up another additional group to focus on that, but we can leverage that work and apply it to this project as well. And so part of it is finding places where there's good work being done that can then be applied to this project. And I think that there's a lot of that that's being done through the committees for the OHPB, as well as the work that's being done here. But I do, like I said, I think that's an open question in terms of how engaged this group wants to be in this process and how active you want to be a part of this process.
Thank you, Dave. John?
Yeah, Dave, this was terrific and a good summary of how things are going. My question is, given that this goes to the legislature January 1, so what, 25 days, is this something that the governor-elect's transition committee sits down with you and OHA on before then? Or, you know, almost immediately, or at least on January 9th, you know, there's the new governor's priorities. So between now and then, is there a transition committee from the governor-elect that gets involved? You know, I noticed when Jeff presented that, you know, that transition committee hasn't sat down with the OHA legislative folks. So is that on your is that on your dance card before January 1?
That's one of our hopes. I know that we have started to meet with a transition team from the governor's office specific to the waiver, but we haven't had a discussion about this specifically. But that is one of the places that we would like to get some insight if there's some guidance or direction. One thing that we did do is in providing issue papers in advance of the transition team. We did provide some background on this process, but it was, again, very high level. And it would be, to your point, helpful to hear where the governor, if there are particular priorities or intentions. And that still is a kind of an open question and a mystery in terms of how influential that'll be in this process. And that's why in some ways it's difficult to say exactly what this process is going to look like, with the expectation that there is still that potential for the new governor to make a change. And this is something that we didn't necessarily deal with in the same way, in the same timing wise as we had last time, but it is a key consideration. So the hope is that, yeah, we will get some guidance or some direction from the new governor on this process.
Thank you, Dave and John. Any other comments or questions? We still have one more presentation next. Just a couple of really quick thoughts from my end. Obviously, not enough time to really be able to debrief and talk through. So I would love another presentation, Dave, in January to kind of keep updating the board on the report that's going to the legislature in January. I don't know if the timing will work out well too, but I'd even love like a webinar in either January or February where we have more of dedicated time and space to talk through this issue, just because I think again, this is going to be really critical, and 5 minutes of dialogue isn't going to be enough right now. So a webinar in January or February would be really helpful. I have a lot more questions about this, but we are running out of time. So maybe I'll just kind of put those two requests that in January, it does become another agenda presentation for the board, and then that we work towards a webinar where we can talk more about this. The question that Brenda posed made me think about how in the past we've had clarification on the board's role about what areas are we a leader, what areas are we sort of an ambassador or an advocate and supporter. So I think it'd be really important for us to clarify what our role in this issue is going to be moving forward. So thank you so much, Dave.
I appreciate it. And I'll reach out to Tara about setting up something for January. Thank you.
All right. All right. Final presentation today is getting an update on the Bridge Task Force. So I am going to hand it over to our presenters, Tim and Stephanie, to have them introduce themselves and provide the presentation.
Good morning, everyone. Thanks for having us. I don't see Tim. Oh, there you are. You just popped up. Good morning. We are excited to be here today, and I know we're running late, so we'll try to keep it as condensed as we possibly can. Is someone going to show the slide deck, or should I? Oh, thank you. My name is Stephanie Caballero. My pronouns are she, her, ella, and I am a member of the Bridge Health care plan. Sorry, I'm used to saying BHP task force. And I am your designee for this specific work group, and I'm also on the Health Equity Committee. And joining me today is Tim Sweeney, who's from the Office of Health Policy. And so today we want to give you an overview of where we're at with the Bridge Health Plan, so that hopefully you can get an idea of where we're headed. We are nearing the end of our process, and we'll cover a little bit of that here today with you. Can I get the next slide, please? So we thought it might be helpful to start with a brief overview of the Bridge Program Task Force and our vision. We're going to show or share more an actuarial analysis that the task force considered in making a recommendation, and also next steps for the program and preliminary final recommendations at the end of this presentation. Next slide, please. So we'll start with an overview for those of you who may not be as familiar. Oh, next slide. Thank you. The general idea for this task force is to come up with a proposal for the Bridge Health Plan, which will provide affordable health insurance coverage and improve the continuity of coverage for individuals who regularly enroll and disenroll for in medical assistance programs, or OHP, due to frequent fluctuations in income. So this is what we call the churn, and the task force really is looking at the coverage for this group, these populations, and really considering the pros and cons of what we're going to be moving forward at the end of our process, which is again nearing. And I'm going to now invite Tim to cover just a few more details, but I also, in case it's helpful, want to share who the task force is made up with. And just as a reminder, we have 17 voting governor appointees, 4 non-voting legislative members. And if you're curious to see who's part of this task force, all of our contact information or our listing is available on the Bridge Health Program Task Force website. Tim, would you like to join me to continue? And I'll come back later.
Great. Thank you, Stephanie, and good morning to the board. It's been a while since I've been back here. But I'm going to go through some of the details of the work of the task force and set up the recommendations for Stephanie to discuss at the end. So, and I'll try to go through some of these a little more quickly since I know we're a little short on time. So the next slide just is a brief reminder of kind of the process and where the Bridge program fits into the post-PHE redeterminations process. And I know you heard more about that this morning, but you could see that it's one of the paths to coverage for folks who are determined no longer to be eligible for OHP coverage once the redetermination process starts. And so the next slide shows a little bit more of what the vision is for this program. And this is as directed by House Bill 4035 last session, and a little bit alluded to already, is that adults with income below 200% of poverty get to stay in their CCOs with little or ideally no cost, no premiums or copays for members, that the plan would cover a robust set of benefits built on the OHP package of covered services, with capitation rates to CCOs that enable them to pay providers at higher rates than in Medicaid, if possible, and that this vision of down the road potentially giving people in this income range a choice between the basic health program and subsidized coverage on the marketplace, which is where this income group would get coverage now. So the next slide highlights sort of the phased approach of implementation that the task force is working with now. And And this is also as directed by the bill, is to consider a phased approach. And the first phase is once the public health emergency ends, OHA is seeking permission from the federal government to keep members who are on OHP now, who are in this income range, to keep them on OHP while the basic health program gets finalized and stood up. So basically, people don't have to leave their CCO, leave OHP to go to the marketplace, only to come back to a CCO in the basic health program at some point in the next year or so, or in the next year after that period starts. And so then the basic health program would be done in two phases. The first phase here, phase 2, is moving folks who were in this temporary Medicaid category, who are on OHP now, moving them into the basic health program, but letting folks who are in a marketplace plan already stay there until the start of the next year, in which phase 3 would kick in, and then everybody in this income range would be eligible for the basic health program instead of subsidized coverage on the marketplace. And then phase 4 is really a down the road, if desired, effort to look at giving folks in this income range a choice between this basic health program and coverage on the marketplace. So the next slide, or the next section, will go over some of the actuarial analysis that was presented to the board, really, or to the task force, in order to inform their development of recommendations for the structure of this program. So the next slide, to go through these at a relatively high level. So the OHA worked with some outside actuaries to develop some estimates of the potential cost of operating a basic health program, as well as the estimated revenue, the funding that we would get from the federal government to do so. And at a high level, this analysis, which was presented to the task force just a few weeks ago in November, suggests that this BHP vision that we talked about, the CCO services, no member costs, and rates that are at least as high as rates paid for OHP members, that this vision is feasible. Projected revenue for each of the populations, so folks who would be coming from the Oregon Health Plan into the BHP, folks who would be coming from the individual market, from marketplace coverage, and people who would enroll in a BHP who are currently uninsured. That for each of these 3 populations, the projected revenue that we would get from the federal government would enable us to cover the costs of CCO services with no costs and at least OHP rates. That said, the revenue and cost estimates are definitely assumption driven. There's a lot we don't know because we haven't done the full redeterminations process over the last couple of years, because people's incomes could have fluctuated multiple times during that time, and we'll learn a lot once the post PHE redeterminations process begins, and we get a better sense of folks' current income and whether they would qualify for this program. And so given that uncertainty, it will be important to continue to monitor that process and to continue to refine both the cost and the revenue estimates as the Medicaid population moves into the temporary eligibility category during the PHE unwinding. The next slide shows the task force also looked at some analysis of what impact the creation of a basic health program would have on existing marketplace plans, on the existing market itself. And the task force was directed basically to consider ideas and solutions to mitigate any negative impact that the creation of a new program could have on the marketplace, in particular as about 35,000 people would be expected to move from marketplace coverage to this BHP. At a high level, the conclusions are that the impact is modest. That doesn't lead to a big worsening of the risk pool of the individual market. It doesn't lead to significant coverage loss in the individual market, but the loss of silver loading, and that's like a whole separate presentation, does potentially affect the purchasing power, especially for marketplace enrollees who right now choose to buy bronze and gold plans. And so basically the direction from the task force is that we continue to look at ways to mitigate this impact, and especially around making it so that the individuals who lose some purchasing power don't really feel that there's some ways to make up for that loss of tax credit dollars. And so the next slide talks a little bit about that. The initial proposal was for a focused 1332 waiver that would build on Oregon's existing reinsurance waiver that could basically capture federal savings and increase the subsidies for people purchasing on the marketplace. And that we worked with carriers. There was a series of meetings with carriers to evaluate some of these ideas, and that one looked to be maybe more substantial than initially thought, more difficult for carriers to do. So instead, the pivot is towards this concept of a gold benchmark to replace the indexing of the value of the tax credits, no longer to be connected to the cost of the second lowest silver plan, but instead to be connected to the cost of the lowest gold plan available on the marketplace. And the idea would be that this would then protect the tax credits for folks who otherwise could see slightly lower tax credits as a result of the creation of a BHP. So the next slide, we are still exploring this. We're not going to have an answer on the feasibility of this, of the cost of this idea prior to the task force finalizing their report next week. We are continuing to work with our actuaries and consultant team to better understand this cost and to develop a high-level feasibility analysis to determine whether this could be done in a deficit neutral way, which is required of 1332 waivers. We expect this initial analysis sometime, I would say, in early 2023, like January, ideally, and that this analysis will inform next steps with CMS and potentially the development of a 1332 waiver to make this change. So the next slide, or in the next section, we'll go through some of the next steps for program development, and this is where we'll try to be a little faster. And so one challenge, or one in particular task, is to solve for some challenges related to the way that American Indians and Alaska Natives in OHP don't have to choose CCOs. They're currently enabled to stay in fee-for-service, but the basic health program can't be delivered through a fee-for-service mechanism. It will be delivered through CCOs. So in order to avoid a situation where AIA and members on OHP going from the Oregon Health Plan to a basic health program would have to, folks who currently choose to be in fee-for-service, where they would have to then elect a CCO in order to participate in the basic health program. We're trying to avoid that scenario. And so the idea is to instead expand Medicaid eligibility for American Indian Alaska Native adults 138 to 200% of poverty, so that they can continue to have this choice between fee-for-service and CCO coverage. And so this would effectively be the bridge program for AIN OHP or AIN people in this income range, so that they could still benefit in the same way that folks moving from CCO coverage on OHP to a BHP do, but also preserve that continued ability to choose fee-for-service instead of CCO coverage. And this provision is part of an 1115 waiver that we have, waiver amendment that we have submitted to CMS that would do both this as well as the temporary eligibility category to keep people on OHP at this once the redetermination period ends. And so far we've received significant support from tribal communities, tribal members on this provision, and we're working with CMS to convey that and to continue to try to get this approved. Next, I might skip over the next couple slides on out of time. We did some work with carriers to address the mitigation of marketplace issues, and we've been working with CCOs, the next slide shows, to sort of make sure that we capture their operational concerns and challenges. And we're going to continue to work with CCOs in 2023 to get ready to implement the program. And then the next slide shows really what the timeline is for what's happening over the next couple of years. Prior to submitting a blueprint, a basic health program blueprint, that will come back to the board. House Bill 4035 directs the board to approve the blueprint before we submit it. And then once the PHE begins to unwind, currently assumed for April, phase 1 of the phase implementation will begin, and people who are currently on OHP will move into this new eligibility category that will mirror the BHP eligibility rules. And we'll continue to work with CMS to finalize the basic health program blueprint and be ready in 2024 to move folks into that. And so throughout the rest of 2023, it will be continued redeterminations, continuing to implement phase 1 and to get ready for the launch of a basic health program. And then the next slide shows in 2024, we will, the plan is to then transition from phase 1 to phase 2, which is when people who come from the Oregon Health Plan will then be enrolled in the basic health program. So we'll be using the BHP federal funds to cover their costs instead of the traditional state federal Medicaid split, and then getting ready for a full launch of the basic health program in January 2025, at which point folks would move from marketplace plans to the basic health program. So that's what the next little bit looks like. And now I'll turn it back to Stephanie to talk about where the task force landed.
I know we're going super fast through this, so hopefully we'll have some time at the end for any pressing questions. Next slide, please. So with the actual analysis that Tim kind of went over, we did provide interim recommendations back in September because we needed to. And so that was what we're presenting to you today is the interim report that we had to submit to the legislature. And so this slide really outlines high-level recommendations that we were thinking in September, and we began to revamp last week at the end of November as a task force, and we will finalize next week to comply with the timeline. We don't have time to go over this in detail, but I'll go over each of them, which essentially in the order in which we are recommending these is: one, we do want to establish the program through section 1331. And then we do want to move into the phase implementation, phases 1 through 3, with continued exploration of optionality for phase 4. This plan will be administered by the CCOs, the coordinated care organizations, and eventual enrollment through the exchange will be an option. We actually discussed a little bit more on that last week. Aligning the contracting and implementation processes with current OHP. We've discussed this in detail as well, trying to reduce the burden on the system and adopting yet one more process so that we can quickly move into the implementation phase and reduce, again, more administrative issues for the CCOs. Capitation rates that enable higher than OHP provider payments, and it hopes to incentivize the insurance companies to join in on this, and also adequate reimbursement for safety net providers. A little bit beyond that, last week we also discussed capturing the importance that safety providers bring to ensuring access for the folks, the populations that will benefit from the BHP. We discussed a CCO service package, no enrollee costs, and waiver or to waive the 1331 requirement for plan choice. And last week, we also discussed incentivizing health-related services, ongoing consumer engagement and oversight, and we talked a little bit about goal benchmarking and mitigation strategies. So again, we understand this is really high level. This is what we submitted to the legislature in September. We are continuing to finalize these with our final meeting is actually next week on the 13th. We are also generally following the vision for the bill. We try to follow the budgetary pieces with also some exploration of potentially the reserves. We want to establish a trust, all in direction and guidance provided by CMS, and really wanting to make sure that the task force submits a comprehensive list of recommendations that we all can agree will help us launch this this plan successfully and provide the best coverage for those who will be impacted. I'll take a pause. I know we're nearing the end. Any questions that you have for Tim and I that we may try to answer in the next 6 minutes or less?
Stephanie, is that your final slide or is there any more?
It is. It is.
Okay.
This is our final slide. Thank you.
Awesome. All right. Thank you so much, Stephanie and Tim and the task force for all your work and the presentation today. Questions from the board? John.
I'd just say, wow, good work. This seems to be shaping up. Complicated, but gosh, it seems like good work, you guys.
Thank you. Thank you. And your very own Kirsten Isaacson is also part of the task force. So I'll welcome her, invite her to chime in and share any thoughts, commentaries, and also if any other questions come up, to join me in answering them as well.
I think you did a great summary and have been representing the board and our kind of overall mission and values very well. So thank you, Stephanie. I think this committee, you guys have heard me say my excitement about this effort so many times of just the idea of having a solution for our churn population is I just trying to keep kind of reminding us of like what an incredible step forward this is in terms of providing care to a pretty vulnerable population in our state, and these intricacies around like, okay, well, we need a waiver from the choice because we want to use our CCO system. So there's like just utter continuity from the patient's perspective in this program. There's been such like thoughtful consideration by OHA DCBS staff, even coming up with this, how do we work around the silver loading issue? Oh, maybe we could do gold loading. Like, I really appreciate the creativity that agency staff has come with to this. It's been really impressive. And then I think this committee itself has, wrestled with some of these issues have not been easy. And I don't, while the committee is coming to a close, I think some of the sticky points might keep being sticky, and we'll see if we hear commentary on some of the rubbing areas when the plan comes before OHPB for review. But I think there's been a lot of earnest conversation and trying to hold true to that initial thrust of how do we take a step forward in terms of making healthcare accessible for more Oregonians. So it's been an honor, and there's lots of good company on that committee.
I will echo the sentiment. It has been extremely challenging at times for many of us, we bring specific lens, but not other lenses that are just feel sometimes way above our heads when we're discussing some of these topics. And I truly appreciate just the genuine participation that everyone has brought to the table, and that shared common goal, right? That we are here to serve this population, and how can we do right by them? How can we make sure we move forward with the right intention and the best possible plan that we can recommend. I think the sticky points, the conversations have been really helpful in understanding that further, and really finding common ground and how we can all gain some buy-in into what we're putting forth. And so I hope at the end of the day, all of us who have devoted how many months to this feel good about the end product, and proud of what we're hopefully doing together and accomplishing together to impact so many across Oregon. So yeah, and if at any point you have any further questions, you can listen to the recordings, or also join us next Tuesday is our final meeting, starting at 8:30. But feel free to shoot any questions to us or to Tim. I'm sure I'm volunteering you, Tim, on the more specific items. We're happy to follow up. Thank you for giving us the space to update you today.
Thank you so much again, Stephanie and Tim, for your presentation. And that basically concludes our agenda for today's meeting. Just a quick reminder that we have a webinar next Tuesday from 8 to 9, which will be an update on the healthcare workforce needs assessment. And that assessment is going to be submitted to the Oregon legislature by February 1st, 2023. And then again, our next board meeting will happen on Tuesday, January 10th from 8:30 to 12. And I just want to thank everybody for your participation and your attention and your engagement today and all throughout 2022. It's been really wonderful working with OHA leadership and my colleagues on the board. So I hope you have a wonderful holiday season, and you get to spend some time with loved ones and have an opportunity to do some reflection through 2022 and some intention setting for next year. So thank you so much, and I look forward to continuing working with you next year. Bye, everyone.